guys, we will be discussing tongue under three parts actually. We can divide the tongue in three parts. So we got this root of the tongue, we have the tip, and the time, and we need to spend more time on this body part. So there's a tip here, obviously tip of the tongue. The most posterior part that is called as the root, which is attached backwards, and the major part of the tongue is what we call as a body. Okay, if I start with the root first, let's start with the root here. When you know root of the tongue or the posterior part of the tongue is, anterior part is relatively free and the posterior part is fixed. And it is fixed to what? It is fixed to certain bones backward, posteriorly, with respect to, with the help of some muscles, some mucosal folds. Like it is attached, the tongue is attached to what? It is attached to the hyoid bone. Like there is a muscle called as the hyoglossus muscle. So that is one attachment. It is attached to the mandible. It is attached to the mandible. It is attached to the styloid process also. It is attached to the styloid process also. So these are the major attachment of the root of the tongue, which is basically two important things. There are two important things to remember. Number one, this attachment of the tongue, the root which is there in the posterior part. This posterior part of the tongue or the root of the tongue, the nerves and vessels, enters through root. So whatever hypoglossal nerve, lingual artery, whatever it is, guys, whatever nerves and vessels you will see in the tongue, the only way they can come into the tongue is from the root. So through the root. And second thing about the root is that these attachments, this attachment to hyoid bone, to the mandible, to the styloid process, these are the ones which are preventing the tongue from falling back. So, why don't we swallow our own tongue? Because of these attachments only. So it prevents tongue deglutition. Right? So that is a little bit about the root. Second thing we said, tip. Now tip, obviously when you see in the normal resting position, when you close your mouth, you will feel your tip of the tongue is touching the teeth and it is touching the central incisors. So it is always in contact. In resting, it is in contact with central incisors. अब आती है main चीज के ऊपर, and that is body. The body of the tongue. Now the major part, that is the body here. But first of all, the body of the tongue can be divided in two parts. We have two surfaces. One is the dorsal surface. We've got the dorsal surface of the tongue, and we have this ventral surface. So the upper surface that you see, so that is the dorsal surface, right? That is the upper surface, dorsal surface, and the one when you fold the tongue and you see underneath it, that is a ventral surface, guys. That is a ventral surface. So dorsal surface is above and the ventral surface is below. So we're going to take these surfaces one by one in more detail and talk about them. As I said, it's a long question, so prepare it. And for your first year, you better be preparing it that way only, because after tongue coaching, they'll be asking about, explain the tongue under the following heading: the body, about the muscles, the lymphatic drainage, the nerve supply, so on. Okay. So starting with the dorsal surface. Now I'm sure you all know that when we look at the tongue here, if this is the tongue, there is a sulcus which is seen, and this sulcus, which is dividing the tongue in anterior 2/3 and posterior 1/3, this is called as the sulcus terminalis. There is a sulcus terminalis, and sulcus terminalis is the one which is dividing the. And first, before I tell you that sulcus terminalis, what it is doing, exactly at the apex of the sulcus terminalis, between the two limb here, we have this foramen which is called as the foramen cecum. The foramen cecum. Cecum is blind basically, so this foramen is right now blind, but this foramen cecum is the side from where the thyroglossal duct, comes out and gives rise to a thyroid gland. I hope you remember the thyroid gland, they develop from the first pharyngeal arch itself, the junction of first and second pharyngeal arch, and we have a foramen present over there between the two lingual swellings. One was tuberculum impar, and then we have this foramen also called as foramen cecum. So here we have a thyroglossal duct which will go down and then divide into the two thyroid lobes. That's why one of the ectopic position of thyroid gland could be the lingual thyroid also. So if you Google this picture, you'll find it. There's an interesting image in which you may see the thyroid gland tongue के ऊपर रखा हुआ है. There you will find the pictures for that. That is called the lingual thyroid. So lingual thyroid is the one when thyroglossal duct doesn't go down and the thyroid gland develops exactly on the tongue itself. So with a sulcus terminalis, as I said, sulcus terminalis, what it is doing, it is dividing the tongue in two parts, in the anterior 2/3 and posterior 1/3. So there's an anterior 2/3 and posterior 1/3 of the tongue. It is divided by the sulcus terminalis. Anterior 2/3 is called as the oral part of the tongue. It's a more anterior place. It's the oral part. और जो पीछे वाला part है, posterior 1/3, that is called as the pharyngeal part. It is facing the pharynx, so we call it the pharyngeal part. Okay. So this anterior 2/3 is what we call as the oral part, and the posterior 1/3 is the pharyngeal part. Now this anterior 2/3, the two things that we need to discuss about this anterior 2/3 is that first, when you look at the entire tongue, it's not only about the anterior 2/3 and posterior 1/3. Tongue में बेटा एक fibrous septum present है. There is a septum which is dividing the tongue in two parts. कभी-कभी carcinoma के case में we can actually remove the half of the tongue also, because everything in the tongue is present bilaterally. So there is if you protrude your tongue and look into the mirror, तो आपको बीच में एक हल्का सा furrow, एक sulcus दिखाई देगा. So there is a median furrow or the midline sulcus is there in the tongue, which is exactly at the level where you have a septum. That septum is going all inside the tongue here, and that's why we have everything too. We have two genioglossus, two styloglossus, blood supply from both the sides. Although it is a midline structure, but we have everything present bilaterally in it. Just like soft palate. Soft palate में सब कुछ दोनों साइड से आ रहा था. So the oral part here, the two important thing about the oral part is we have a furrow which is called as a median furrow or a median sulcus. I'll show it to you. And the important thing to discuss in the anterior 2/3 are the papillae. The lingual papillae, the taste buds will be there on it. So that's papillae here. Posterior 1/3 of tongue is quite rough. Posterior 1/3 is quite rough, and it is having a lot of lymphoid tissue present. And this lymphoid tissue which is present on the posterior 2/3 of the tongue is the one which is forming this lingual tonsil. In the Waldeyer lymphatic ring, which we still have to discuss, I told you we'll discuss the lymphatic drainage in the later part. So lingual tonsils, in the Waldeyer lymphatic ring, side we have palatine tonsil, obviously which is a lymphoid tissue, and phloem. In the lower part we have this lingual tonsil which is present on the posterior 1/3 of the tongue. So this is just first the division here, that how the tongue is divided in anterior 2/3 and posterior 1/3. If you quickly look at this picture here, so this gives you a fair idea. You can clearly see this median furrow here, that's a sulcus here, that's a median sulcus here. Or you can say it's a median furrow. Obviously this sulcus beta, it's a sulcus terminalis, I'm writing ST here for the sulcus terminalis. And then obviously the posterior 1/3, if you look at this posterior 1/3, pura rough dikh raha, that is rough because of the tonsils here, or the lingual tonsils are present in this part. All the lingual tonsils are present in this part. So let's first focus on the anterior 2/3. What is there in the anterior 2/3? Well, obviously we said anterior 2/3 is known for having papillae. Papillae, that is lingual papillae. Right? So guys, we are still discussing what? We are still discussing the dorsal surface only. We went to the baat nahi kar rahe, we are still discussing the dorsal surface, and in the dorsal surface now we are only focusing on which part? The oral part, that is anterior 2/3. Oral part, which you already know, it is just another name for anterior 2/3 of the tongue, is the oral part. As we said, we have lingual papillae present there. The lingual papillae on which the taste buds will be located, those lingual papillae will be there. So basically when you use the word papillae, and this will go in the histology also, that when you use the word papillae, they are the projections of the lamina propria. So papillae here is for the projection of lamina propria. Lamina propria. Projections of lamina propria. इसको हम कोरियम बोलते हैं. That's another word for this. This is also part of the corium. याद रहे तो ठीक है, otherwise doesn't matter. Corium, or the projections of the lamina propria, which is also called as corium. Now these lingual papillae, I'm sure you must have read this thing in your +1/+2 also. There are 4 types of papillae we have. The first one here is called as valate papillae. Valate papillae. We can also call it the circumvallate also because of the circular shape, so we can call them circumvallate papillae also. So valate or circumvallate papillae, that's the first one. Okay, before we talk about all these papillae, एक diagram बनाते हैं in which we'll keep marking all these papillae and everything where they are present. We'll keep coming back to the diagram and पूरा all the major, what do you say, the prominences or the things that we have in the tongue, we can mark on that particular diagram itself. So guys, before I talk about the valate papillae, let me draw the diagram for you. So let us say this, if this whole thing is the tongue, and here is the sulcus, we said that is sulcus terminalis, that has to be the foramen cecum. Right, so you can see tongue divided in anterior 2/3 and posterior 1/3. Posteriorly, guys, there will be epiglottis. I hope you remember this from the discussion in the larynx, that we said epiglottis is present behind. There is epiglottis, that is upper topmost part of the epiglottis, and then what you see that from the epiglottis to the tongue, there are some mucosal folds are stretching here. One in the center and one which are on the sides. We call them glossoepiglottic fold, and there is a space between them which is called as the bellicle. Abhi wahan aate nahi hai. We'll talk about it. So that's the upper border of the epiglottis, and you can see the mucosal fold which are connecting the epiglottis to the tongue. One in the midline and 2 are on the sides here. Now, as I said, let me focus on one thing at a time. We already know this portion here. That's a posterior part, that's a pharyngeal part, and that's an anterior 2/3. So if this here is the posterior 1/3, the pharyngeal part, this obviously is the anterior 2/3, and this is what we are focusing at this point of time, the anterior 2/3. The valate papillae, the circumvallate papillae. Now these circumvallate papillae, they are the largest papillae. इनका diameter भी around 2 millimeter तक होता है, so they are visible with the naked eye also. And these circumvallate papillae, they are situated exactly in front of this sulcus terminalis, like this. This is sulcus terminalis, of course. I hope you're drawing it with me. There is sulcus terminalis, and these papillae here, they are the valate, the circumvallate, or simply you can say valate papillae. So let me write down a few points for this valate papillae. As I said, these valate or circumvallate papillae, guys, first of all, they are the largest. Out of all the 4 papillae that we have, the largest one is the circumvallate papillae, and the size, the diameter vary from 1 to 2 millimeter. 1 to 2 millimeter is the diameter, and as I said, that's why they are very clearly visible also. 8 to 10 in number can vary a little. एक तो ऊपर नीचे हो सकता है, but usually there are 8 to 10 in number. So if I talk about the number, there are 8 to 10 circumvallate papillae. Location we just said where they are present, they are aligned in front. They are aligned in front of sulcus terminalis. They are aligned in front of the sulcus terminalis. And you know, when we'll discuss the histology of the taste buds and especially the valate papillae, you will see they're shaped something like this. Now this is how the lining epithelium will be, and you will see it will dip down inside, and this mushroom kind of structures will be seen from the surface. So if this is the surface, that's the lining epithelium. Let us say this whole thing is the lamina propria here, the one which I'm putting a double line here. That's the lamina propria. You can see this. You can see this sulcus. These sulcus. This is a papillae, guys. This is a papillae. This is a circumvallate papillae looking at, and there is a sulcus which is covering it all around. It's a section, so it's look like this, but it's circular. It is circular, and we have a space around it. And within that space, this lining epithelium is the one which is having taste buds. So taste buds in the circumvallate papillae, you will not see them on the surface. That's an important point to remember, that the taste buds are present in the sulcus. The taste buds are present in the sulcus. When the lining epithelium dips inside, that is where you have the taste buds. In fact, the seromucous glands are also opening in the sulcus only. So the surface here is not having the taste bud. When it comes to circumvallate papillae, their taste buds are not on the surface. Their taste buds are present within the sulcus part, within the sulcus. Sulcus को moat भी बोलते हैं. These are some, these are terms which आपको जरूरत नहीं है याद रखने की. But let's say if somebody asks you what is that moat, M-O-A-T, moat. The sulcus or the moat in which we have these taste buds only. So this is the first type, guys, circumvallate papillae, the one which are largest, very few, only 8 to 10, and they are aligned right in front of the sulcus terminalis. Now the second type of the papillae, we'll talk about are called as the filiform. They are filiform papillae. So let me first tell you that where these filiform papillae are. उसके बाद भी आके इसको वापस discuss करते हैं. These filiform papillae are present on the almost entire dorsum of the tongue. So if I just let me choose a color for it. If I take a blue color here, so you will see that filiform papillae are present, are spread on almost the entire dorsum of the tongue. So they're the most numerous one. So these filiform papillae are spread on the what do you say, on the dorsum of the tongue. जो टंग का ना जो एक velvet appearance होता है, we call it the tongue looks velvety in appearance. That velvety appearance of the tongue is actually because of this filiform papillae itself. So these are, if I have to write few points about it, this first of all, out of all the papillae, these are the narrowest. These are the narrowest papillae. Number 2 point here is that they are most numerous. They're most numerous papillae in the tongue. And number 3, their location. Where is their location? Where they're located? They are located on the dorsum of tongue. So like almost the entire dorsum of tongue, they're spread on the entire dorsum of the tongue. And better, this filiform papillae are the one which are responsible for that, what appearance we say, the velvety appearance. The velvety appearance of the tongue is because of this filiform papillae. And when you'll see this again in the histology slides, these will look like this conical projections coming out like this. That's how they'll be. ऐसे ऊपर निकले होंगे. These are called as the filiform papillae. These are the one which are called as the filiform papillae, which will come out as a conical projections. They come out as a conical projection. Let me write that also here, like a conical projections. Unlike circumvallate papillae, where you saw that it was more of a dipping inside. The lining epithelium was like dipping inside, and in the furrow there were taste buds. Here, basically, they are projection on the surface only. ऊपर की तरफ project करना है as a conical projection. Very small though, very very small, but yes, they are the one which gives the typical texture of the tongue, that जो roughness है, जो velvety appearance है tongue का, that is because of these filiform papillae itself. Okay, third in the line are the fungiform. The fungiform papillae. Let me again tell you the location of the fungiform papillae, and then we'll talk about them. But the fungiform papillae are present on the tip of the tongue, and they're also present on the margin. So tip and margin is the location. Let me use a different color here. If I'm using a red color here to show it, this is where the fungiform papillae are, and they are spread along the margin of the tongue. They're present at the tip and on the margin of the tongue. And you know, this is, I would say they are the second largest. After circumvallate papillae, they are the second largest. They can also go up to 1 millimeter in size. Let me just write down these points for you. So the fungiform papillae, as you saw, they were present on the tip. They are the one which looks like a red round-headed. If you bite your tongue, not hard, just if you gently bite your tip of the tongue and see it in the mirror, आप अपने tip of the tongue को gently bite करो and just look closely in the mirror, you can see some dots on it. Some red dots you will see on this, and those red dots, those red round-headed structure that you will see over there are the fungiform papillae itself. So they are red and round-headed. So histologically, if I talk about them, they will look something like this. Like this. So again, it is not a furrow, it is a projection from the surface. It is projecting from the surface here. So that's how the lamina propria is showing this projection, and this time the taste buds will be seen on the surface here. The taste buds will be seen on the surface. That's how the fungiform papillae will look like. So they are red, round-headed. As we said, they are the second largest. So their diameter can approach up to 1 millimeter. Circumvallate papillae were like 1 to 2 millimeter. They can be like twice the size of this fungiform papillae. But yeah, this is also relatively large. So they are 1 millimeter in size. And the location, we said again, they are present. Their location is where it is at the apex, or you can say tip, and margins. So it is located at the tip and the margin, or the apex and the margin of the tongue. So till now, vallate, filiform, and fungiform here. Now coming to the last one, the fourth one is called as the foliate. Foliate papillae, vestigial in human, but yes, the fourth papillae that you will still see the remnant of those in human, that is foliate papillae. You know, these foliate papillae, if I again show you the location here, the foliate papillae are again present in front of the sulcus terminalis, on the sides, and they are present like a vertical grooves or vertical ridges are there. Let me use a green color for that. कुछ ऐसे दिखेंगे आपको. So these are the one which are called as the foliate papillae. So vallate, filiform, fungiform, and your fourth and the last one, that is a foliate papillae, which are again in front of the sulcus terminalis on the sides, and they are present like a vertical groove. They are like an inconstant vertical groove. That's how they are defined. They present like a inconstant vertical grooves and ridges. You can see they are present like vertical grooves here. Location, what we said, location, it is in front. Once again, they are in front of sulcus terminalis. They are in front of sulcus terminalis, near the margins. Obviously, on the side of the tongue, so near the margins. So that's what the location is. As we said, the important point here is that foliate papillae are the one which are rudimentary. They are rudimentary in humans. We don't need them. They are rudimentary in humans. They are more developed in other animals like rabbit, the cow, buffalo. So they are the ones which are having these kind of papillae more developed. Rabbit can be very well developed in rabbit, but in human they are just rudimentary. So these are the four types of papillae. So as I said, we are still talking about the dorsum part of the tongue, and the dorsum of the tongue we are still talking about the oral part, that is the anterior 2/3. Now, from this, let's move on to the posterior 1/3 of tongue. हमने ये discussed किया. We talked about this anterior 2/3. Just to remind you again, this diagram, you can add one more thing, that there is a median sulcus or median furrow, which I showed you in the picture also like this. Make sure to draw that. This is a median furrow, the median sulcus or the median furrow. Okay. Now coming to this posterior part, the posterior portion, we said all we have here are this is all rough region here, because we do not have papillae there. In fact, we have lymphoids present in this region here, and that is what is contributing to the Waldeyer lymphatic. These are the lingual tonsils basically. So these are the lingual tonsils. I'll write all this for you. Let me just label it for first. These are the lymphoid follicles. These are the lymphoid follicles. Your one diagram should be enough to explain the entire dorsum of tongue, so that you don't have to draw it over and over again. And as I said, this posterior part is connected to the epiglottis also, and it is connected to the epiglottis. The most posterior part is basically connected to the epiglottis by 3 folds. One in the middle, and that's why the one which is in the middle is called as a median. Median glossoepiglottic fold. epiglottic fold. Makes sense? It is present between the tongue and the epiglottis, so it is called as glossoepiglottic. And there are two lateral glossoepiglottic. So obviously median तो एक ही होगा, and then we have two lateral glossoepiglottic fold, and that's why in the most posterior, between the most posterior part of tongue and this epiglottis, we have the space which I believe I discussed the space with you in larynx also. That in front of the epiglottis, one space is called as the pre-epiglottic space. वो तो उसके नीचे होती है. This space is called as the vallicula. This space here is called as vallicula. V stands for the vallicula. Right, so vallicula is a space basically present between the median and lateral glossoepiglottic fold. Median and lateral glossoepiglottic fold. So we are now talking about which part? That is the pharyngeal part. We're talking about the pharyngeal part, and pharyngeal part is the posterior one-third. So basically, it's the posterior one-third that we are now talking about. And we said this, first of all, obviously, there are no papillae. This is the part with no papillae. Number two, it is uneven. When you see it, it looks uneven, and it is uneven because of what? Because of the presence of lymphoid follicles. Because of the lymphoid follicle, presence of lymphoid follicles, and that is what is what we call as the lingual tonsils. There is a lingual tonsils. And another important thing here is that mucous membrane, which is coming from this posterior part of the tongue, is going toward the epiglottis. We said by two folds, median glossoepiglottic and so mucous membrane. And see guys, this mucous membrane which is covering the posterior one-third of tongue, it is not only going backward. Posterior one-third of tongue के side में क्या है? Palatine tonsil. So this mucous membrane covering the posterior one-third of tongue is continuing on the side to the palatine tonsil and then going backward also, reaching the pharynx part, or we can say epiglottis part basically. So mucous membrane is continuous with, I should say it is continuous with tonsils obviously. When I'm writing tonsil, I should write palatine. It is continuing with the palatine tonsil on the side. And the same epithelium, na? If you look at the tongue, posterior one-third of tongue, or you can look at the soft palate, or you look at the epiglottis, सबका lining epithelium same ही है, stratified squamous. So mucous membrane is continuous with the palatine tonsil and posteriorly to what? To epiglottis. Posterior to epiglottis. In what form? Via median and lateral glossoepiglottic fold. Median and lateral glossoepiglottic fold, and obviously between this median and lateral glossoepiglottic fold, the space which is present is called as the vallicula. If you remember our discussion in the larynx, then I hope you remember guys, we said the space to tongue or epiglottis in each of the space, that is vallicula. But there is a space outside this vallicula also. If I just want to quickly take you back to this picture here, in fact let me take you back to this picture, because this is a picture in a reverse order though this is the epiglottis guys, this is the upper border of epiglottis, let me mark it for you. This is the epiglottis, right? Look at this fold in the center, that is median glossoepiglottic fold, let me mark this for you. This is median glossoepiglottic fold. And of course, the one which is on the outside, that is a lateral glossoepiglottic fold. This one here is the lateral glossoepiglottic fold. And this is the space we're talking about when we highlight around. This is the space which is called as the vallicula. Let me put V for the vallicula here. Okay, that's vallicula. Obviously, you can see the larynx behind that part here. Epiglottis, obviously, this is all larynx here. And this fold will be the airy epiglottic fold. Remember that guys, that is an airy epiglottic fold. This one here is an airy epiglottic fold. From the arytenoid cartilage to epiglottis. Which this here is the airy epiglottic fold. So what you see, that this lateral glossoepiglottic fold, now please pay attention, this lateral glossoepiglottic fold, and in continuation if you go backward, this airy epiglottic fold, the space that you see outside this, in this region here, this is where you have what fossa? The pyriform fossa. If you remember guys, that smuggler's pouch, the pyriform fossa was outside the laryngeal wall but inside the pharyngeal wall. Obviously this is a pharyngeal wall, pharynx. You can see this maybe one of the constrictor muscle you're looking at here, that's a pharyngeal wall here, and this here is a laryngeal wall. So obviously that's a vallicula here. So sorry, that is a pyriform fossa. So that's another way to look at the pyriform fossa, is that you can see that lateral glossoepiglottic fold. This lateral glossoepiglottic fold is the one which is separating the vallicula from pyriform fossa. आपसे कोई पूछे कि vallicula और pyriform fossa के बीच में कौन सी membrane है? So it's a lateral glossoepiglottic fold. What membrane is present between the pyriform fossa and the main inlet of the larynx? Then it is airy epiglottic fold or epi. Right? I hope this clears it for you. Now this is about the dorsal surface. We talked about the anterior two-third and posterior one-third. Now let's go to the ventral surface of the tongue. नीचे वाला part, the ventral surface, that is the inferior part. So all about the dorsal part till now, and now we are moving to the ventral surface. But a ventral surface of the tongue, it is also called as the inferior surface. And simply हम इसको inferior surface बोल सकते हैं, superior surface and inferior surface, or more commonly used term is the dorsal surface and ventral surface. Let me draw it for you, and then with the diagram itself, I keep telling that what are things. So how exactly you see the ventral surface when you fold your tongue like this? When you raise your tongue, like when you put a thermometer or you put a sorbitate, so that's how you lift your tongue. So that's how you're able to see. So मान लीजिए you're lifting it from the front, and that's how someone is elevating the tongue in front of you. So that's how the tongue is lifted and you're seeing it from. Now you probably, I'm sure you must have noticed that when you open your mouth and you lift your tongue, you will see there is a fold, there is a mucosal fold which is connecting the tongue to the floor of the mouth. And that midline fold, here it is what you call as a frenulum. More expanded form, we call it frenulum lingulae. So exactly in the midline here, we have this mucosal fold. When you lift your tongue, you will see there is a mucosal fold. This is called as the frenulum linguae or lingulae, that is frenulum linguae. This frenulum linguae, what I said it is, this frenulum linguae, I'll write it here only, we don't have to write separately anything about it. It is basically the mucosal fold. It is a mucosal fold connecting tongue to the floor of the mouth. Connecting the tongue to the floor of the mouth. कभी-कभी होता है ना, this frenulum linguae is too much, I mean, we have too much of frenulum linguae present. If when you open your mouth and you see the frenulum, it is present very much in the posterior part only. But imagine if you have excessive frenulum linguae which is present to the more anterior part here. So आपकी tongue ऐसे floor से चिपकी रहेगी. You will not be able to lift your tongue too much. So having a broad, or if you have a large frenulum linguae, it's not a good thing to have, because that will lead to something called as a tongue tie. It is tying your tongue. So long frenulum linguae or long short bolna chahiye, short and expanded forward. So short and expanded lingulum, frenulum can lead to the tongue tie. Your tongue floor se chipki rahegi. You will not be able to lift your tongue too much. So there are simple surgeries. Basically, we just dissect this frenulum linguae and the person can again regain the activity of the tongue. Okay, on the side, when you lift the tongue and you see the under surface of the tongue, the inferior surface, we have a very translucent type of mucous membrane there. So you can kind of see through it. Try karna, go in front of the mirror and lift your tongue, and you can very clearly see the frenulum linguae in this middle. And on the side, you will see a bluish structure over there, which is a vein, which is basically the deep lingual vein present there. So you will be able to see the deep lingual vein underneath the mucous membrane, which is running bilateral like this on the side of the frenulum. So this here is the lingual vein that you can see. Lingual artery and lingual nerves are also here, but you can't see them. They are more deeply placed. Nervi or arteries are deeply placed, so you can't see it. So when you lift your tongue, you're only able to see the bluish structure over there. So that's a vein you are seeing. Whereas the artery, even if I just write about that here itself, that lingual artery and lingual nerve is also present, and it is present more medially. They are present medial to this deep lingual vein. Medial to deep lingual vein, but can't be seen. They are deeply placed, you are not able to see them. The only thing you can see is the deep lingual vein, but the lingual artery and the lingual vein both are present there. Lingual artery and lingual nerve both are there. Medial to the vein, but more deeply placed, so not visible. More laterally, what is visible, you will again see a mucosal fold present over there like this. And this mucosal fold present more laterally is called as a plica fimbriata. Plica fimbriata. So plica fimbriata is again a mucosal fold that you will see more lateral to it. So you have 3 prominences. So please do it today. Just go in front of the mirror, lift your tongue, and you should be able to see all of them very clearly. Midline, you have frenulum. On the side, you will see the bluish structure, which is the deep lingual vein. On medial to that deep lingual vein, you will the lingual artery now, which you can't see. And more laterally, we have this the plica fimbriata, another mucosal fold present there. When you go toward the more posterior part, the part of the tongue which is attached to the floor of the mouth, what you will see there here is the opening of submandibular glands. The Wharton's duct is opening here. There is sublingual sublingual papilla. That elevation over there is a sublingual papilla, and this sublingual papilla is the site where the Wharton's duct is opening. Remember Wharton's duct, guys? Wharton's duct is the name given to the duct of submandibular gland. Jabki sublingual glands, the name of the gland is sublingual gland because they are actually present deep to the tongue only in the mucosal fold. So we have a mucosal fold which is present somewhere here in this manner, which is having numerous opening inside. So numerous opening inside here. So this fold here is called as again a sublingual fold. That was a sublingual papilla where the duct is opening. This is a sublingual fold. That's a sublingual fold. So this sublingual fold is basically covering the sublingual gland. So sublingual glands are somewhere here only, and sublingual glands are having numerous ducts which are opening directly here. So this sublingual fold, what are they doing? Let me just write it here itself. That they are overlying. They are overlying the sublingual gland. They are overlying the sublingual gland, and of course these छोटे-छोटे ducts आपको दिख रही हैं. These are the openings of the sublingual gland ducts itself. There is one major duct which is opening on the side of this frenulum linguae. That is where we have sublingual papillae, is for the Wharton's duct. So again, nothing to write about it separately. You obviously, when you write the answer, you can try to show it in the diagram itself. This is how the ventral surface or the inferior surface of the tongue will look like. 3 elevations, 3 prominences: the frenulum, the deep lingual vein, and the plica fimbriata that you will be able to see. More close to the floor, where the tongue is attached to the floor, you will see close to the midline we have the opening of the Wharton's duct on the sublingual papillae, and we have a sublingual folds of the mucosal fold which are basically covering the sublingual gland, and directly their ducts are coming out and pouring their secretions in that part. So ये तो regarding the surface of the dorsal surface and ventral surface, how we divide the tongue, anterior, posterior, and what is there in it, and about the papillae also. Now come to the another important part on which separately you usually get a question on this. When they ask you the long question, they ask you a separate question on the muscles of the tongue. 2 types of muscles are present in it, both skeletal only, but there are 2 types of muscle that we have in the tongue. The 2 types of muscle that we talk about in tongue, as I said, they are all skeletal muscle only, but we have intrinsic muscles. We got intrinsic muscles and we got some extrinsic muscles. Intrinsic and extrinsic muscle. Now again, everything is given in the textbook, but you don't have to read everything in detail. Right? You should know that how to filter it, what is important to read and what is important to carry forward also. Right? There are certain things which you want to read for the knowledge sake, but not asked in the exam. Okay, makes sense. But don't try to read anything and everything, which probably will not be useful in the examination, or शायद बाद में उसकी बहुत ज़्यादा ज़रूरत ना पड़े. One of them is the intrinsic muscle. You should know the name of the intrinsic muscle. You should be able to draw it, and you should know the function. Origin insertion चक्कर मत पड़ना कि which septum it is coming from, then how it is moving, and then how it is inserting. That just don't waste your time on it completely. So even if you get a question on the muscles of the tongue, your main focus will be on the extrinsic muscle. But yes, anyways, we have to talk about the intrinsic muscle also. Well, a few points about the intrinsic muscle is number 1, that they are not attached to bones. Well, that's why they are intrinsic. They're inside the tongue only, so they're not attached to bone. And second important thing is they are present. This, I hope, something with the sign is for the present. They're present in the upper part of tongue. When you take a cross section, if you take a coronal section of the tongue, so you will see these muscles, the intrinsic muscles are present in the upper part. Most of the extrinsic muscles are present in the lower part. They're spreading in the upper part of sides also, but intrinsic muscle ऊपर वाले part में होती है, and extrinsic muscle are present in the lower part, and that is why the intrinsic muscles are able to change the shape of the tongue. When you think of intrinsic muscle, beta, they can change the shape of the tongue. They're like, I can narrow my tongue like this, I can flatten, broaden like this, I can furrow it. So all this furrowing, flattening, making the dorsal surface convex, concave, all these changes in the shape of the tongue are done by the intrinsic muscle. You under in the काम कर रही है. Whereas the extrinsic muscles of the tongue are responsible for the movement of the tongue, protrusion, retrusion, sideways, pulling the root of the tongue upward, backward. So all this done by the extrinsic muscle. So let me name it for you first. We said we have 4 intrinsic muscles and we have 4 extrinsic muscles, and again bilaterally present. 4, 4, 4, 4. So obviously, if I say in total there will be like we have like 16 muscles, but yeah, we have to look at one side here. So we have 4 intrinsic muscles. Now, what are the 4 intrinsic muscles we got? We got a muscle that is called as a superior longitudinal muscle. Superior longitudinal muscle, and I would suggest you people to write it like this. Second number bit, I wanted to write down on second number as transverse muscle. I'll tell you why I'm asking you to do that. Transverse muscle. Inferior longitudinal muscle, and then of course the vertical. The reason I made you write like this, in books they have written superior longitudinal, inferior longitudinal, because I wanted to remember that transverse muscle is the one which is separating these two. Superior longitudinal or inferior longitudinal को transverse muscle separate करना, that's the one which is separating. I'll draw it for you, but before that, now what are the extrinsic muscles of the tongue? Obviously, which are having the bony attachment. In the cranial nerves and at different places, you already must be knowing about these names. You must have come across these names already. Like one of the muscles, the most important one is the genioglossus. The very, very important, the genioglossus, coming from the genial tubercle of mandible. Then we have a muscle called as hyoglossus, coming from the hyoid bone. We've got a muscle coming from the palate, that is palaedoglossus. We discussed this muscle in the palate also, the palaedoglossus. And then we have a muscle coming from the styloid process, that is styloglossus. So these are the 4 extrinsic muscles we got, and 4 extrinsic muscle. Although I will draw a separate diagram for you for the extrinsic muscle, but guys, to show the intrinsic muscle all together, the best possible diagram is the coronal section. Like if I protrude the tongue, and I take a coronal section like this, मान लीजिए ये मेरी tongue है ऐसे, and if I take a coronal section this way, so I will be able to see the muscle like this. Superior longitudinal ऐसे run कर रहा होगा, so superior longitudinal will look like 2 dots. Inferior longitudinal will also look like 2 dots because they are running longitudinally. Okay. Transverse muscle will be seen all in all because you've taken a transverse section along the muscle, so I will be able to see the transverse muscle very clearly, and vertical muscles are also to be seen, which are running superior and inferior. So as I said, the section that is the only thing you got to understand is that you have to look at the coronal section of the tongue, or you can say the transverse section of the tongue basically. So when I take a transverse section of the tongue, it looks a little like this. We said throughout, this is a furrow, that was furrow I was talking about, that the depression that we have in the tongue, and from that furrow extending throughout the tongue is a fibrous septum. From that furrow throughout the tongue, we have this fibrous septum which is separating the tongue in 2 halves, completely 2 separate halves. This is called as a median fibrous septum. This here is the median fibrous septum, which is पूरे tongue के अंदर present. It is throughout the tongue, and it is dividing the tongue into right and the left half. Okay. Looking at the intrinsic muscle, we said transverse muscle will be seen running this way. This is how the transverse muscle is located. Obviously, one half is here and other half is here. So there are 2 transverse muscle we have. एक side, एक side. Both are attaching to this median fibrous septum. Vertical muscle will be seen like this. As the name suggests, they are vertical muscles. This is the one which is above, so that is superior longitudinal. That's how it looks like. I told you they're running anterior posteriorly, the longitudinal. So when you take a section, they look like this. These are the superior longitudinal muscles. And the one which are present below, these are the inferior longitudinal muscles. So we got the vertical. These are superior longitudinal muscles. This is transverse. And that's how the inferior longitudinal muscle is present. Okay. So I don't have to draw any extrinsic muscle here, but अगर मुझे draw करना हो, if I go with that, I'll try to use a different, what do you say, color for this. Guys, let us say this is a section of the hyoid bone. Let's say that's a greater corner of the hyoid bone you're looking at. It's a coronal section, obviously the hyoid bone is having greater corner which are projecting backward like this. So we've taken a coronal section. So from this greater corner of the hyoid bone, as I said, I'm taking a different color. There is a muscle that you will see which will run in this manner. That is obviously the hyoglossus muscle. I hope you remember that very, very important muscle इसके relation discuss किए थे. So that is hyoglossus. And the styloglossus muscle will be seen more outside like this. Because styloglossus will be running again posterior आगे तरफ आएगी. It will coming like this from the styloid process into the tongue. So that's how. These are the 2 extrinsic muscles which I want to show you in this picture. One is the styloglossus, and the one coming from the hyoid bone, that is hyoglossus. Although I said I'll be drawing this diagram separately for you, but these are the 4 intrinsic muscles that you need to focus on as of now. Vertical, transverse, उसके ऊपर superior longitudinal, below we have inferior longitudinal. The only reason I wanted to draw this in this way because hyoglossus muscle, remember that it is separating which muscle? You know, sometimes you may have these weird questions, but as you can see, the hyoglossus muscle is separating what? It is separating the inferior longitudinal muscle to styloglossus. So styloglossus is more on the outside. As a matter of fact, all these muscles which are inserting into the tongue, extrinsic muscle, tongue के side में attached होती है. Most of them are attached to the sides of the tongue. Intrinsic muscle are occupying the middle part, and the outer part is occupied by the extrinsic muscle. Well, we said vertical, superior longitudinal, transverse, inferior longitudinal, but what exactly are their function? If we go to the function part, the vertical muscle, if I start with the vertical muscle, that is responsible for making the tongue broad and flattened. That's a tongue position. They made the tongue broad and flattened. That is done by the vertical muscle. When the vertical muscles contract, obviously when the muscle will contract, the tongue will become relatively thin here. But becomes thin like this, but it will expand sideways. So it becomes broad and flat, more of a broad and flat. That is done by the superior longitudinal and inferior longitudinal. Well, superior longitudinal muscle will be ऊपर की तरफ present है. So superior longitudinal muscle will make the dorsum of the tongue concave. Whereas inferior longitudinal, when it contracts, it makes the dorsum of the tongue convex. Right? So that's the two muscles which are working against each other. So the superior longicular muscle is the one which makes dorsum what? Concave. This muscle is very much in the upper part. So when this muscle will contract, the tongue will come like this. There is slight depression will be seen in the tongue here. So it becomes concave. Inferior longitudinal is quite below. When that muscle will contract, the tongue will curve in this direction. So dorsum surface will become what? Convex. So inferior longitudinal, it makes dorsum convex. And what about transverse muscle? Transverse muscle, it makes the tongue narrow. It's a muscle which is running transversely. Imagine if this muscle will contract here, so obviously the sides of the tongue will come close to each other. Agar puri tongue hai, and there's a muscle running like this and this. So when the muscle will contract here, so that will make a tongue narrow. And the more the tongue becomes narrow, it gets elongated also. Narrowing and elongation of the tongue is done by the transverse muscle. So this transverse muscle, the function is to narrow and elongation. Narrowing the tongue and elongating the tongue, that is the function of this. Right? So I hope you can understand the function of these muscles once you understand that how they are located. Muscle tongue beta aise, superior longitudinal upar hai, upar wale muscle contract karega, tongue will be like this. So dorsum will become concave. Inferior longitudinal is present below, so when this will contract, tongue niche ki taraf curl karegi. So dorsum becomes convex. Vertical muscle are running like this. So vertical muscle, if they are running in this manner, so when they contract, obviously this surface becomes more flattened. So we have more flattened surface. And the more the surface is flattened, the tongue becomes broad. So it will make the tongue flat and broad. अब किसी भी flat, जिसको flat करोगे तो obviously automatically broad हो जाएगी. And then we have a transverse muscle which is running like this in this manner. Every time this muscle contract, it will bring the two margins of the tongue close to each other. That will make the tongue thicker, or you can say it will make the tongue narrow, but it will elongate the tongue here, like this. Narrow and elongated. So this is about the intrinsic muscle here. As I said, intrinsic muscle, if it is a long question, obviously you have to write about intrinsic muscle. Please, it is written in BD Chaurasi or any other book. Do not write about the attachments of the intrinsic muscle. Complete waste of time. कोई extra marks आप gain नहीं करना. So don't do that. Something that you need to focus on is the extrinsic muscles of the tongue. That you got to pay more focus on. The four extrinsic muscle, and it is always advised that you draw the diagram, because by the diagram itself you can easily remember that what is the function of those muscles. So thankfully the name of these muscles are such that origin and insertion is everything in the name. Yeah. So when we talk about the extrinsic muscles, four of them are present. Like, let me help you draw a diagram for this. So let's say here this is the palate. Someone a couple of days back someone was asking me that is it okay to draw these line diagrams that we draw in the class? Yes, absolutely. That's easy to bana rahe hain. It is absolutely right if you draw these line diagrams. See, don't fall for the trap कि BD Chaurasi वाला diagram नहीं बनाया तो marks नहीं मिलेंगे. See, let's not go into that. BD Chaurasi is also a book which is followed here. Like there are certain countries where BD Chaurasi नाम भी नहीं पता उनको. So they are still drawing the diagram from somewhere. Maybe they are drawing it from the Keith, or they are drawing some line diagram. So it's not that you take any book as a standard book for the for the diagrams or आपको वही diagram follow करने. It's just up to your convenience. I always tell you that your diagram should be technically correct. It should give the relative information well labeled. Nobody is going to check you आपकी क्या drawing skills हैं, how you shading the muscles and all that. But if somebody asks me about the color coding के बारे में don't worry about it. Cartilage can be drawn blue. Cartilage can be drawn with blue color, that way. Colors coding, especially about except for the artery, vein, nerve maybe I told you pencil and you can use a yellow color over it. And the brown color for the muscle. Rest anything and everything you can use any color. Nobody is going to object to it. So परेशान मत हो कि यार what color should I use for this synovial lining के लिए क्या color होना चाहिए? What color should be for the cartilage? What color should be for the erector tissue? Any color, anything. Barring those four major colors that you need to keep an eye on. Obviously green for the ligament. Otherwise rest, you can use any color. Okay, so guys, let us say this here is a palate, and of course this is the tongue. This muscle is discussed. Now, as I said, the bony prominence is the four muscles. One is palatal process. One must be coming from the palate here, palatal process. One must be coming from the styloid process. This is the styloid process at the back. That is styloid process. Then one is coming from the greater cornua of the hyoid bone basically. So here we go. This is the, let's say, the hyoid bone present below. And we also have a muscle coming from the mandible. There are genial tubercle present on the mandible. If you remember, there are two genial tubercles, superior genial and inferior genial tubercle. So guys, this here, let us say, is a cut section of the anterior part of mandible. And draw one also like one inside also. So this is mandible. This here is hyoid. So obviously the four muscles which are running into the tongue from these different directions. Okay, let me start with the styloglossus first. The muscle coming from the styloid process. The muscle originates from the tip of the styloid process and from the anterior surface. And I hope you remember again from our previous discussion that styloglossus muscle is present superficial to hyoglossus. Styloglossus muscle merges with the hyoglossus, so hyoglossus muscle is the one which will be coming like this. The direction is important. If you draw these directional muscle fiber correctly, you will never forget their function. That muscle is coming from the hyoglossus. Obviously, muscle which is coming from palate, that is a palatal process. And the most important muscle, the examiner will be looking at one particular muscle that आपने ठीक बनाई है, लिखी है, and that is genioglossus. There are some genial tubercles which are present on the inner surface of the mandible. We have superior genial tubercle to inferior. Inferior genial tubercle give origin to the muscle called as a geniohyoid. Geniohyoid. Whereas a superior genial tubercle, the one that is present, superior genial tubercle will give attachment to the muscle that is genioglossus. So this is superior genial, that is inferior genial. So from the superior genial tubercle, the muscle will originate, and it is having three fibers. The anteriormost fiber will go like this and turn and go into the tip. The middle fiber are the one which are going into the dorsum of the tongue. And the lower fibers are the one which are going to the hyoid region. So three different directions. I'll tell you more about this muscle, but this muscle here is genioglossus. This is genioglossus. This here is palatoglossus. This of course is the styloglossus. the one which we have discussed in detail during the triangles also, that is hyoglossus. I hope you remember we have discussed about the relations of hyoglossus also. So the four extrinsic muscles, the palato, stylo, hyo and genioglossus. Now look at this. First of all, don't worry about the origin insertion. जो दिख रहा है वही लिखना है, कुछ अलग से स्पेशल लिखना है. I don't have to write any fancy attachment for these muscles. Palatoglossus muscle is originating from the palatine aponeurosis, or you simply can say palate also, that will do, from the palate or palatine aponeurosis, and it is inserted on the side of the tongue. Remember the palatoglossal fold was there, which is present in front of the palatine tonsil. So this is coming from the palate, and then it is inserted to the side of the tongue, that is palatoglossus. Now think about what will be the function, because palatoglossus muscle is present on the side and very much toward the posterior side. So every time this muscle will contract, this will basically pull the root of the tongue. This will pull the root of the tongue above. So the function is important. The function is it will pull the root of tongue. It will pull the root of the tongue. Styloglossus, guys, the muscle says styloglossus. Now think about what should be the function. If you look at the direction of the styloglossus muscle, and again the styloglossus muscles, they are basically coming to the side. I told you extrinsic muscles side mein aati. Intrinsic muscles are more inside. Extrinsic muscles are more on the sides. Okay. So styloglossus muscle is coming from the styloid process, and again it is going to the side of the tongue. In fact, even more lateral to hyoglossus. It's very much on the side here. So every time this muscle will contract, what will it do? It will basically pull the tongue backward, and obviously styloid process above, so it will also pull the tongue upward. So in this direction, it will take the tongue. So pulling the tongue backward and upward. So this is the muscle which will pull the tongue backward and upwards, backwards and upwards. Those who are having their exam of the head and neck coming up, I told you this HNF mein one of the very important long question is the tongue. I would say after thyroid gland and parotid gland and tongue, these are probably the three most important long questions. Hyoglossus, we have talked enough about hyoglossus already. We've seen hyoglossus relations, but from the function point of view, guys, again look at the muscle is originating from the hyoid bone, especially from the greater cordon, and then this muscle is again inserting onto the side. So every time this muscle will contract, what will do? It will depress the sides of the tongue. Side the bone line, it will depress the side of the tongue. And see, if you look at this tongue here, if you depress this side of the tongue, the tongue becomes what? The dorsal surface becomes convex. अगर आप इस साइड को भी नीचे पुल करो, इस साइड को नीचे पुल करो, तो tongue becomes like this. It becomes convex. So hyoglossus muscle, it depresses side of tongue, and because it depresses side of tongue, it makes dorsum convex. It will make the dorsum of the tongue convex. But this is the three muscle: palatoglossus, styloglossus, and hyoglossus. And obviously, the muscle which needs a special attention is the genioglossus. But let me just mark the fibers in here, and I'll write separately about it. As I said, there are three fibers: upper, middle, and lower fiber. So if I may do that, this is the upper fiber here. I'm writing U for the upper fiber in the diagram only. अगर आप कर सके तो ऐसा कर लीजिए. Then we have this middle fiber. This M is the middle fiber of the genioglossus, and this L is the lower fiber of genioglossus. So this is the muscle which we need to know a little more in detail. Upper fiber, middle fiber, and lower fiber. और तीनों fiber का function अलग है. We have a different function for all these three fibers. So genioglossus. And don't be surprised if you get a short note, a very small short note question on genioglossus also. That is also a possibility. It's probably is the most important tongue extrinsic muscle to be remembered. Genioglossus. So guys, origin of the genioglossus, we said it is from what tubercle? It is from the superior genial tubercle. Superior genial tubercle. I hope you know, but let me just write that. That is present in the mandible, on the inner surface of the mandible. We have a superior genial tubercle where we have the origin here. Insertion for all the three fibers is separate. As we said, the upper fibers first. Upper fibers of this muscle are going and inserting to the tip. Middle fibers of the genioglossus are going toward the dorsum of the tongue. Obviously, off tongue likhne ki zarurat nahi, you know that. That is tip of the tongue, dorsum of the tongue, and lower fibers. And the lower fibers, as you saw it in the diagram, वो नीचे तरफ आ रहे थे. They are basically going to what? They are going to the hyoid. They are going to the hyoid bone. Look at the diagram once again, and again don't mug up the function. Just look at this and understand it. अगर आप इस diagram को देखो तो diagram itself tells you that what a function बेटा. This fiber, the upper fibers are going toward the tip. So obviously when the upper fiber will contract, it will pull the tip backward. So it basically retract the tip of the tongue. जब आपका tongue protruded होगा, so this will help in the retraction. Tip of the tongue को retract करने में help करेंगे, because obviously the muscle will contract and will pull the tongue in this direction. Middle fiber is going toward the dorsum. If the middle fiber is going toward the dorsum, so it will depress the tongue, because it is pulling the tongue downwards, so it will depress the tongue. And lower fibers are going toward the hyoid bone here. They're going into the tongue, and then obviously they're going to the hyoid bone. When I say lower fiber, obviously tongue में भी जा रहे हैं. So lower fibers are going into the tongue, into the substance of tongue, and ultimately going to the hyoid bone. So what they will do, these are the one which helps in the protraction. These fibers, when they contract and they'll pull in this direction, so the tongue will go outward. So the main muscle for the protraction of the tongue is also genioglossus. Again, understand this. Anterior fiber, upper fiber, I should say. Upper fiber, they retract the tip of the tongue, but the posterior fiber, on the other hand, they protract the tongue. They will protract the tongue outside. And because these fibers, the lower fibers are the one which are basically holding the tongue to the mandible, and they are basically preventing the tongue from falling back. Apart from other structures, we said tongue is attached to the styloid process and this one and that one. But if you look at the hyoid bone, palate and styloid process, they are all present inferiorly, superiorly, and posteriorly. So they are giving attachment to the tongue. But the main muscle, the main structure which is preventing the tongue from falling back, when you sleep, your tongue is not like falling back into your respiratory passage, and that is because of the tone of this muscle, and that muscle is the genioglossus. More specifically, the lower fibers of genioglossus, and that's why this muscle is also called as the safety muscle of the tongue. Like we have a safety muscle in the larynx, that was a posterior Remember the posterior what? Posterior cricoarytenoid. Here this is the genioglossus. So just to write that one, the tip of the tongue, upper fiber go to the tip of the tongue, they helps in the retraction. They retract the tip of the tongue. The fibers which are going into the dorsum of the tongue, they are helping in the depression of the tongue. They depresses. And the one which are going to the hyoid bone and to the tongue. Otherwise, it will not be tongue muscle. It is going back to the tongue, posterior to the tongue, and then to the hyoid bone. That is responsible for protrusion. So it protrudes. And because it protrudes, just correct the spelling, that is protrudes, P-R-U, protrudes. This is called as a safety muscle of the tongue. This is called as the safety muscle of tongue. It basically prevents the tongue from falling back. It prevents the tongue from falling back. So this is about the extrinsic muscle and the intrinsic muscle. But एक छोटी सी गलती जो मैं आपको याद दिला देता हूं, because I've seen people doing it. When they ask this question that describe the tongue muscles, many people write the extrinsic muscle and they forget about the intrinsic. So don't over focus on the intrinsic muscle, but like completely ignore नहीं करना उनको. Do write about the intrinsic muscle name, draw that cross section, and just tell their function and nothing else. Please do not waste time on their attachment. So you just have to draw this diagram here, show the intrinsic muscle, and in the diagram itself, it's possible. Just write down that what is the function, what exactly they are doing to the shape of the tongue, basically. And extrinsic muscle, yes, you have to tell about their origin insertion. Rest of the origin insertion are quite simple. Remember one thing, extrinsic muscles are outside. So every time you think about the insertion of any extrinsic muscle, like palatoglossus, from the palate to the tongue, but where to the tongue? To the side of the tongue. Genioglossus, genial tubercle to the side of the tongue. So whether it is tipped, whether it is the dorsal tongue, but onto the side. Okay. If the muscle says styloglossus, from the styloid process to the side of the tongue. Hyoglossus again to the side of the tongue. None of these muscles are present right in the core, right in the center, not very close to the median raphe or median fibrous septum. Okay, from here let's talk about the arterial supply. Arterial supply of the tongue. Again, and I think in BD Cholasidis just wrote the names of the arteries which are supplying it, and I always like to draw it so that you remember it more efficiently. So guys, let us say this here is the tongue again. और मुझे इसका blood supply discuss करना है. So again, for the reference sake, let me draw the hyoid bone. Just for the reference, this is the hyoid here, and that is tongue. But to explain the blood supply, obviously external carotid artery is the one which will supply. So let me go with the same thing which we have discussed earlier also, that it is internal carotid artery which is a continuation of common carotid, and let's say here we have external carotid. So this is internal carotid artery, and let's say this is external carotid, that is of our concern. What branches from the external carotid do supply the tongue? Well, undoubtedly the main artery has to be the lingual artery, the direct branch. So lingual artery is the main artery supplying the tongue. Now what you will see that lingual artery is basically passing above the hyoid bone, deep to hyoglossus muscle. We should keep labeling them together, otherwise it will be difficult later on. Guys, this artery is obviously the direct branch of external carotid called as a lingual artery, which obviously is the major arterial supply to the tongue. So you know, when this lingual artery goes forward into the tongue, I told you every artery, every nerve which is supplying the tongue, which is they enter from the root part of the tongue and they go forward. So yes, that is also coming from the posterior part and going anterior. And this lingual artery is given of these branches which are supplying it. Like this branch of the lingual artery is called as a deep lingual artery. It's the same deep lingual artery which will accompany the deep lingual vein. The same deep lingual vein which we are able to see from the ventral surface. So you can't see the deep lingual artery, it's deep. You can't see it. It's deeply situated. And because this is the these are the branches of lingual artery supplying the dorsum of the tongue. So what do you call it? You call them dorsal lingual artery or branches. So they are the branches of the same artery only. Let me just highlight them so there is no confusion. Lingual artery is giving off deep lingual artery and dorsal lingual artery. One is going and supplying the tip of the tongue, and another one is supplying the dorsum of the tongue. And just to add something to your knowledge, but this deep lingual artery is not only supplying the tip of the tongue, it is a major arterial supply to the sublingual gland also. If I draw a sublingual gland for you, let's say here, sublingual gland, it is present below the tongue only. So the sublingual gland is also supplied by the same deep lingual artery. Just an added information. Sublingual gland is supplied by the deep lingual artery, which is a branch, or you can say it's a continuation of the lingual artery. Then any other artery, remember that which should be supplying the tongue, that is the facial artery. Facial artery, one of the branch of facial artery given off in the neck. Stag branches, S-T-A-G, stag. So let me draw the facial artery first. This is the facial artery. You can make out with its course. Can use a different color for this. That's a facial artery. And but there is a branch of facial artery given off in the neck. Stag branches, that is T. Tonsillar artery. So tonsillar artery is not only supplying the palatine tonsil or soft palate, it is also supplying the posterior and the outer part of the tongue also. So it's a tonsillar artery, the tonsillar branch of the facial artery. This here is the tonsillar artery. I'm just trying to use the same color for the individual arteries, so that you branches देखने में आसानी. What else? Ascending pharyngeal artery. Ascending pharyngeal artery, the one which we can't see. That ascending pharyngeal artery, let's say this. So this here is the ascending pharyngeal artery. That is ascending pharyngeal artery. So that's the third one in this list. I'm giving a different color. So we have some lingual branches, ascending pharyngeal artery. So we have some like direct branches in the ascending pharyngeal artery which are also supplying the posterior part of the tongue. The posterior part of the tongue. No name, a specific name branches. So we have these branches coming from ascending pharyngeal artery supplying the posterior part of the tongue. So guys, अगर major arteries की बात करें तो lingual artery of course, undoubtedly the main artery, and we also have a contribution from facial and from the ascending pharyngeal artery also. Which part of facial? That is a cervical part of facial artery, specifically the tonsillar artery. Venous drainage, guys. Venous drainage. Just like we already saw that we have what vein? We have a deep lingual vein which we saw on the ventral surface. Deep lingual vein is there, and this deep lingual vein is called as basically the principal vein. This is the principal vein of tongue, the main vein of the tongue. The maximum venous drainage is by this, the deep lingual vein. Then we have some venae committents. Then we have venae committents. Some people call it vena committantes. So vena committents, they are basically they run with certain artery. Usually होता है किसी brachial arteries we have two vena committents. So you along with some major artery, you will see some vena committant also. So like the vena committant which are present with lingual artery. But surprisingly, we have some vena committant which are running along with hypoglossal nerve also. Again, this is something which I told you in the relations of hypoglossal, that you will see hypoglossal nerve is running superficially, and there are two vena committant running along with it. So generally, आपको nerve के साथ vena committants नहीं दिखते, but yes, here along with the hypoglossal nerve, you will see the two vena committants are also present there. So guys, the lymphatic drainage. Okay, we'll again understand this lymphatic drainage with the help of the diagram. And let me tell you something in the beginning. Lymphatic drainage, obviously, we have a tip of the tongue draining somewhere, side is draining somewhere, the dorsum and the posterior part somewhere. The most important or the critical part to be remembered for the lymphatic drainage of the tongue would be the one which is having a bilateral drainage. जो भी part of tongue की lymphatic drainage दोनों side पे होगी, both the side of lymph node. That is more of a concern because these are the ones which are of main concern. Carcinoma of the tongue can spread bilaterally through those from that region. So if somebody is having a carcinoma of the tongue in the part where the drainage is only on one side, you can remove the lymph node on one side only. But if it is affecting the portion of the tongue which is having a bilateral lymphatic drainage, this दोनों side में lymphatic drainage हो रहा हो, that becomes problematic because you have to remove the lymph nodes bilaterally then. So guys, let's say this here is the same diagram again. Let me go with the sulcus terminalis, and just for the reference, although we don't need it here, that is circumvallate papilla. If I draw a midline here, because we have to discuss the lymphatic drainage here, so if this is the midline here, and let's look at it at one side at a time. The tip of the tongue, the lymphatic drainage from the tip of the tongue, they are draining into the lymph node which are just below the tip of the tongue here. That is the submental lymph nodes. Submental lymph nodes, they're draining into the submental lymph nodes. That is from the tip here. The lymphatic drainage from the side and from the dorsum of the tongue. The lymphatic drainage which is coming from the side and from the dorsum of the tongue. So it's very easy to remember. Tip of the tongue, submental. You go more posteriorly, that is toward the dorsum of the tongue and the side, that is into the submandibular. So submental, then submandibular. And then you go more posteriorly, the posterior one third of tongue is into the deep cervical lymph node. They are more posteriorly placed. So then we have this submandibular lymph nodes. Submandibular lymph nodes. As you can see, that is coming from the dorsum and from the side. And from the posterior one third of the tongue, the lymphatic drainage goes into the deep cervical lymph node. Deep cervical lymph nodes. So that's not the difficult part to remember. Posterior one third into the deep cervical, anterior two third the major part into submandibular, but the tip of the tongue into the submental. The important thing is the portion which is having a bilateral lymphatic drainage. Let me highlight that for you. Posterior one third of tongue, guys. The posterior one third of tongue and the area which are close to the midline, including the tip also, they are having a bilateral lymphatic drainage. Let me just tell you that this color I'm using here, this yellow highlighter I'm using here, is for the bilateral lymphatic drainage. For the bilateral lymphatic drainage. So posterior one third of tongue, यानी कि इस side का भी it will drain into the deep cervical lymph node, and then always the both sides are draining into the opposite side also. And the same story here. If you look at this one, this portion is draining into the submandibular lymph node. But not only this, even the portion which is on the other side will also drain into the submandibular lymph node of the side. And obviously same story goes to the other side as well. So midline region of the tongue, including the tip and the posterior one third of tongue, they have a bilateral lymphatic drainage. तो बेटा अगर इस एरिया में कार्सिनोमा हुआ, so bilateral spread of cancer के chances बढ़ जाते हैं. So you have more chances of spreading of cancer bilaterally, and that's why it's a more problematic part. If you have a cancer of the tongue on one side, in anterior one third, you can remove the tongue of that side, and you can then remove the lymph node of that side here. But having a cancer of the posterior one third of tongue or in the midline, close to the median furrow of the tongue, is always problematic because you have to remove probably the entire tongue and also the bilateral removal of the lymph node as well. Nerve supply. Another important part on which the questions are asked, but this is something which we have already discussed. So much is with our time delay, guys. When you think of the nerve supply of the tongue, once again, if I use a picture for this, and let me use the epiglottis and those two folds also. That is sulcus, and these are circumvallate papilla. We काम करते हैं. Let us divide this tongue into two halves, right and the left half. On this side, let's talk about the general sensation. Now, general sensation from the anterior two third of the tongue, entire anterior two third of the tongue, I should say. General sensation from anterior two third of the tongue is carried by what nerve? By the lingual nerve, which is a branch of mandibular nerve. From posterior one third of tongue, it is done by the glossopharyngeal nerve. And from the most posterior part of the tongue, where the vallicula is present, guys, here, the vallicula and this upper part of the epiglottis is by the vagus nerve. But which branch of vagus nerve? That's internal laryngeal nerve, which is a branch of vagus. This is general sensation की बात है. Lingual nerve, glossopharyngeal nerve, and internal laryngeal. On this side, if I talk about the taste sensation from the anterior two third of tongue, except circumvallate papillae. Anterior two third of tongue, except circumvallate papillae, the taste will be carried by the chorda tympani with the help of lingual only, but yeah, the nerve is chorda tympani, which is a branch of facial. Posterior one third of tongue along with circumvallate papillae. posterior one third of tongue along with circumvallate papillae. What nerve is that? That is glossopharyngeal. So whether it is general sensation or taste sensation, posterior one third of tongue is by the glossopharyngeal nerve. But in this case, circumvallate papillae are also, taste sensation of circumvallate papillae is also by glossopharyngeal nerve, and nothing is changed in the posterior one third, because again the posterior one third of tongue, it's the same internal laryngeal nerve branch of vagus will carry the taste. So that is about the nerve supply. Anterior two third of tongue, general sensation lingual nerve. We हमने discuss किया हुआ पहले cranial nerves. It's just a recap only. Posterior one third glossopharyngeal, and then most posterior part of tongue it is interlaryngeal. If on this side if I talk about the taste sensation, anterior two third of tongue except circumvallate papillae, quarter tympani, circumvallate papillae and posterior one third of tongue that is glossopharyngeal, and then most posterior part the same nerve again, that is interlaryngeal nerve branch of vagus. Okay, and very lastly about one important clinical condition I'll tell you about. I've been telling you about the clinical condition throughout also, like lymphatic drainage, about the carcinoma, the safety muscle of the tongue, that is genioglossus. So those are point you can write in the clinical anatomy. But one more clinical anatomy point which I want to tell you about is hypoglossal nerve injury case where the tongue deviates to the same side. I don't know if I told you this thing in the cranial nerve also. If not, let me tell you here that this is about the sensation. What about the motor supply? Muscles. Although you know it, but let me write it because भूल नहीं जाना कि muscles of tongue are supplied by what nerve? They are supplied by hypoglossal nerve. They are supplied by hypoglossal nerve except one. Exception तो हर जगह. Except which one? Palatoglossus. Except palatoglossus. And if you remember, palatoglossus was supplied by what? VAC, vago-accessory complex. Except palatoglossus, which is supplied by the vago-accessory complex. So in the clinical condition, what I was saying is that if there is a hypoglossal nerve injury, on one side, of course, and then you ask the patient to protrude the tongue बाहर निकालो. So you will see that there is a ipsilateral deviation of tongue. Now this is something different because usually in the nerve injury there is a contralateral deviation. If you ask someone to like if my bicep muscle is paralyzed, obviously my elbow will go into what? In the extension, because triceps will take over, and vice versa. But tongue में क्या होता है? If my right genioglossus is paralyzed, my tongue will deviate toward the right side only, not toward the left side. Well, why this so? That is because of the muscle genioglossus, guys. Now look at me. Let's say this is the right genioglossus muscle and that's the left genioglossus muscle. If I use both the genioglossus muscle, then only I will be able to protrude the tongue like this. Like the straight protrusion of tongue is by the use of the both genioglossus. Now imagine my right genioglossus is not working. If my right genioglossus is not working and you ask me to protrude the tongue, so I will protrude the tongue only using the genioglossus, the left one. So left genioglossus muscle will contract, the left side of tongue will try to come out, and the tip of the tongue will deviate toward the side of the lesion. If you want it side की tongue बाहर ही नहीं आ रही, because the right side tongue is not coming out and only left side tongue is coming out, so tip of the tongue is deviated toward the side of the weakness. So only when you ask the patient to protrude the tongue, ऐसे नहीं कि you just ask the patient to open the mouth and show the tongue, कुछ नहीं दिखने वाला. You ask the patient to open the mouth and protrude the tongue. So when you try to protrude the tongue, you will see the tongue deviates toward the side of the lesion. So ipsilateral deviation will be seen, which is not seen in any of other cranial nerve injury. This is deviation on the side of the lesion. That's a special thing about the hypoglossal nerve injury. The deviation is seen toward the side of the tongue. But as we said, what is important? When the patient is asked to protrude the tongue. You have to add this point when the patient is asked to protrude the tongue. Another important clinical anatomy that you must have seen, if not in real, you must have seen in movies also, that if somebody is having a angina pectoris or heart attack, they suddenly give them a pill and then they put that pill under the tongue and then suddenly their heart pain is relieved here. But that is true. That is sorbitrate. The sorbitrate, this medicine is basically given sublingually. This is given sublingually. So basically we place it under the tongue. And it is placed under the tongue because of rich circulation there, and it will go directly into the systemic circulation. The problem is one can eat sorbitrate also, or any other medicine. If you eat any other medicine, the point is that medicine will go into the stomach. From the stomach lining or from the intestine lining, it will get absorbed. It will get absorbed and it will go into the portal vein. From portal vein, it will go into the liver. From the liver, it will go into the heart, and then it will go into the systemic circulation. So बहुत लंबा process है. Angina pectoris, obviously somebody is having a heart attack. So angina pectoris case where you have given the medicine which you have to put under the tongue, which will readily absorb into the rich vasculature present over there. You can see the deep lingual vein was visible over there. Imagine. So if the absorption of the medicine can be done from there itself, it will directly go into the systemic circulation, bypassing the portal circulation. So portal vein or circulation में काम नहीं है, directly वो पूरी body में circulate कर गया, and that's how those medicines work very faster. So sorbitrate sublingual is given because because the sublingual portion is very rich in the circulation, and this is obviously done in case of the angina pectoris. In the ESC, what our discussion would be here, एक तो auricle का बेटा nerve supply बताना चाहिए आपको. This auricle here, you should do the nerve supply, that what nerve is supplying where, like great auricular nerve, auriculotemporal nerve, lesser occipital nerve, where exactly they are supplying, and about the two major arteries supplying it. Nothing much. Don't waste your time on the external auditory canal and all that. Your main short note here in the ear is on the tympanic membrane. So one main focus should be on the tympanic membrane. Everything about tympanic membrane, its layers, its histology, its angle, the two parts and everything. Very rarely they might ask question on these ear ossicles also, malleus incrustates. But again, that's not a very common question, but आपको पता होना चाहिए how these bones are arranged, what are the main prominences we have, and where they are attached, especially the attachment of the malleus and the attachment of the stapes here. The one question which is expected from the ear, which you should know about, is the middle ear canopy. Now, I'm sure you all know that what is external ear, middle ear, internal ear. So that's the middle ear here, and this is one middle ear, guys. It is like few millimeter wide only. In the narrowest part, it is just 2 millimeter only. Imagine. So you have to discuss about the anatomy of something which is at one given point of time is just 2 millimeter wide. So you got to understand the walls of the middle ear. What is lateral wall, medial wall, roof, floor, anterior wall, posterior wall, and there's a universally accepted diagram which is a cube, diagram of a cube or a box in which you can understand the middle ear cavity wall. Agar directly middle ear, if you try to understand the middle ear directly with the picture of the atlas or the kind of images which are given in the BDC, it's very difficult. You understand that cubical box that I'll discuss with you, and then you try to compare it with other pictures that I have, and then you'll find that it's nothing much. So question middle ear, maybe it's again a short note only, and they ask about describe the walls of the middle ear. So you have to describe all the 6 walls, 4 walls, roof, and the floor as well. So let us start our discussion with in the ear. We'll start our discussion with the external ear, and that too we'll talk about the nerve supply and the blood supply. So let's go very quickly with that part. So if this here is the external ear, I want to pay attention or give time to the topics which needs attention and which need to be discussed in detail and important also. Some topics which are just to be done for the sake of completion, थोड़ा सा हमको जल्दी कर सकते हैं. So like let's say you're looking at the external ear from the outside. So this is the lateral surface that you're looking at here in the diagram, and the one which is on facing inside, that is the medial surface. That obviously is the medial surface here, and that is the lateral surface, the outer surface. So when you look at the outer surface, the lobule of the ear, this is the lobule of the ear, which is basically lower 1/3. It is supplied by the great auricular nerve. Well, we have discussed enough about the great auricular nerve in the posterior triangle of the neck. So that great auricular nerve is taking care of the lobule of the ear. That is the lower 1/3 of the auricle, and on both the surface. The important thing is both the surface, but outer surface as well as inner surface, or you can say lateral surface and medial surface. The entire lobule is supplied by great auricle. But when you look at the upper 2/3, this is lower 1/3. No? When you look at the upper 2/3, we have a different nerve supply on the outside, and we have different nerve supply, I'm putting a dotted line, on the medial side. So on the lateral surface of upper 2/3 and medial surface of upper 2/3, the nerve supply are different. The nerve which is supplying the lateral surface on the upper 2/3 is the auriculotemporal nerve. That's the auriculotemporal nerve, and again you know about the auriculotemporal nerve. It is a branch of mandibular nerve, the posterior division of mandibular nerve, auriculotemporal nerve. Whereas the medial surface, the one which is facing toward the scalp, the medial surface is supplied by the same upper 2/3 only. It is supplied by the lesser occipital nerve. It is supplied by the lesser occipital nerve. So lower 1/3 में no issue. It's just the great auricular. Upper 2/3 में you have a different nerve on the outside and on the inside view. And when you look at the area which is close to external auditory canal, guys, this area which is in and around the external auditory canal, let me use a highlighter here. This area is supplied by the auricular branch of facial and Arnold's nerve. I hope you remember Arnold's nerve is a branch of vagus. Auricular branch of facial and Arnold's nerve, which is a branch of vagus nerve, they are supplying the skin in and around this external auditory canal and this concha and Simba concha part. So this central wala part, we have the vagus nerve and facial nerve branches are contributing to it. So because we need to know about the general sensation of the face, like where ophthalmic nerve, maxillary nerve, mandibular nerve is. So in that continuity, you should know about the sensory innervation of the ear also, which nerve is supplying what part of the auricle in what region. So regarding the nerve supply. Blood supply, nothing to draw, just remember that blood supply to the external ear is by 2 arteries. The 2 arteries which you can expect closest to the ear. One is superficial temporal artery, which is going exactly in front of the ear like this, superficial temporal through the parotid gland, and one is a posterior auricular artery, which was going backward. So the 2 branches of external carotid artery supplying it is the superficial temporal artery. There is a superficial temporal artery, and we have posterior auricular artery. I'm sure you know about both of them. They both are the branches of external carotid. So from this external ear nerve supply and blood supply, which I just explained it to you because sometimes there could be a spotting question or could be a viva question, grand viva question on that part. Otherwise, you will not expect any kind of theoretical question in your exam on this external ear. The question which is to be asked is on the tympanic membrane. That's a very important short note in fact. Now guys, look back at this picture here. If you look at the tympanic membrane, I want you to understand 2-3 things on the picture itself, ताकि मेरे लिए आसान हो जाए to explain it to you. But this here is external auditory canal, right? This is external auditory canal, which is leading to the tympanic membrane. This oval tympanic membrane, which is almost 10 millimeter and into 9 millimeter. So it's just a case of only 1 centimeter of this tympanic membrane. The first thing to be noted here is that you can see an angulation here. The tympanic membrane is not straight; it is slightly angulated, and there is an angle of almost 55 degrees. There is an angle of 55 degrees with the floor of external auditory canal here. So that's one thing that you should know. And you know, when you put a torch, when you put a light on the tympanic membrane, there is a cone of light which will develop because of 2 reasons. One, it is angulated; it is not straight. And secondly, the center part of the tympanic membrane, if you see, it is stretched inside. See the tympanic, it's not straight. You can see there's a pull in this direction and in this direction, and that convexity of the pull is exactly most at the center here, which is called as umbo. I'll tell you what it is. Out of the 3 ear ossicles, the one which is attached to the tympanic membrane is the handle of the malleus bone. So this here beta is a handle of the malleus bone which is attached to the tympanic membrane. And the one which I'm pointing at right now, I hope you can see that. The one where I pointed at right now, that process of the malleus is called as a lateral process of the malleus. Ye do word yaad rakhna. That is a handle of the malleus, this one, and there is a small projection which is called as a lateral projection, or you can say the lateral process of the malleus, because some part of the tympanic membrane is having a specific attachment to that. Having said that, let's talk about the tympanic membrane in more detail. And I said it's a short note question, so we've got to cover it in short, and we have to cover up all part in there. Tympanic membrane. If I talk about the shape and size, well, this is oval in shape, as we said, oval in shape, and the size is 9 into 10 millimeters. This tympanic membrane is oval in shape, 9 into 10 millimeter, and as I said, it makes a angle of 55 degrees with the floor of meatus, external auditory meatus, the floor of meatus, it makes an angle of 55 degrees. So see the tympanic membrane. Embryologically also, I told you that tympanic membrane is having 3 layers. The first cleft, the only cleft we have, was giving rise to the outer layer of tympanic membrane. The first pouch was giving rise to the inner layer of tympanic membrane, and then we have a middle layer also. If you look at the tympanic membrane, a schematic diagram here to tell you that this here is a skin layer, the outer layer, the cuticular layer, and because tympanic membrane is having a slight angulation because of the pull inside, so I'm going to draw it like this. That is the outer layer. Just draw it with me and I'll explain it to you. This here is a middle layer, and this one here is the inner layer, which is basically the mucous membrane. So these are 3 layers of tympanic membrane. If you're looking at tympanic membrane from the side, so you'll be seeing there are 3 layers. The outer layer here is made up of skin, so that is called as a cuticular layer. There is a cuticular layer. I'm using this red color for the cuticular layer. The middle layer is fibrous. The middle layer is fibrous, so this is called as the fibrous layer. And the inner layer is made up of mucous membrane, so that's a mucosal layer or mucus layer. As we already said, this is the point of maximum convexity of the tympanic membrane, and the point of maximum convexity is called as umbo. This point of convexity is called as umbo. And guys, fibrous layer is the one which is basically attached to the handle of the malleus. Then this is the point where the handle of malleus is attached. And because of the handle of malleus attached to it, which pulls it inside, and that gives rise to the umbo, the projection is formed. Okay. So just the first idea here that we have 3 layers here. The outermost is cuticular, the middle layer is fibrous, and the inner layer is mucosal layer. Cuticular layer, the fibrous layer, and the inner one is the mucosal layer of the tympanic membrane. Cuticular layer, guys, if I think of cuticular layer, it is obviously made up of skin. So अगर ये skin का बना हुआ है तो what is the lining epithelium there? What is the usual lining epithelium for the skin? And that is the stratified squamous epithelium. The stratified squamous epithelium, that is a cuticular. So outer layer of tympanic membrane is made up of stratified squamous epithelium. Middle layer is fibrous, इसके बारे में बात करते हैं. But before I tell you about the inner layer, because it is made up of the mucous membrane, so the lining epithelium there is a low columnar epithelium. You can say simply columnar epithelium. The low columnar is a more appropriate answer. So we have a low columnar epithelium of the mucosal layer. So obviously outside skin, inside mucosal layer, one is stratified squamous, one is having a low columnar epithelium. But the middle layer, the fibrous layer is made up of collagen fibers. So this fibrous layer, if I talk about the middle layer here separately, middle layer of tympanic membrane is made up of fibers, and those fibers are present in 2 groups. We have outer radiating fibers, and we have inner circular fibers. Outer radiating and inner circular fibers. ये कुछ ऐसे है. Outer that means more on the lateral side and on the medial side. So when you look at this middle layer, the fibrous layer, the outer layer, the inner layer is circular. So it's like मान लेते हैं inner layer है. So we have circular type of fibers in this manner. And the more on the outside are the radiating fibers which are present in this way. So that's the 2 types of fibers you see in the fibrous layer. We have outer one which are radiating fibers, and the inner one are arranged in a circular manner. Right? ये तो regarding the 3 layers of tympanic membrane: mucosal, then we have cuticular, and then we have middle layer, which is the fibrous layer, having divided in 2 parts: outer radiating and inner circular. अच्छा बेटा, tympanic membrane जब अंदर attached होता है, if I just take you back to this picture here, although this picture may not give you the complete idea, but still, this tympanic membrane, when it is attached to this bone here, above and below and on the sides here, there is a sulcus present inside. एक depression है, एक sulcus present है in the bone, and the tympanic membrane is adherent into that sulcus. And what happens is the middle fibrous layer is forming a thickness around it. अभी ये जो circular fibers है, देखो, these circularly running fibers, the outer one, the circular fibers here, these circular fibers which are present more outermost here, they become very, very thick here. They become very, very thick, and they can be seen as a fibrocartilage ring. They form a ring here which is made of fibrocartilage. So they become fibrocartilage ring, and this fibrocartilage ring is present inside the bony sulcus. So temporal bone is having a sulcus. उस sulcus के अंदर this fibrocartilage ring is attached. What is fibrocartilage ring? That is basically the fibrous layer, thickening of the fibrous layer. The peripheral part of the fibrous layer is thickened, and that is forming this fibrocartilage ring, which is attached to that sulcus in the bone, which is called as tympanic sulcus. आप ऐसे imagine करो कि there is a big pipe over there, and if you just एक उसके अंदर groove बना दो, just make a groove inside the pipe here, and then you attach a plate inside that, and just make sure that the plate is actually basically fixed into that groove on the sides. So that's a kind of sulcus which is present in the bone, which is called as a tympanic sulcus, and that tympanic sulcus is having this fibrocartilage ring attached to it. This fibrocartilage ring, which is made up of the middle fibrous layer. ये जो हमने thickening बनाई है इस diagram के अंदर, these are the one which I'm talking about here. This is the fibrocartilage ring. These are the fibrocartilage ring I'm talking about, which are attached in tympanic tympanic sulcus. They are attached in tympanic sulcus or attached to tympanic sulcus. Tympanic sulcus is a bony sulcus. The upper part when it's absent, it is present all around. Right? So that's a fibrocartilage which is made up of the thickening of the peripheral part of this tympanic membrane. If you look at the tympanic membrane, if you look at the tympanic membrane, this is how it's going to look like. Tympanic membrane will look like, it's a oval membrane like this. This here is a fibrocartilage ring which is present here, so it's quite thick here, so no problem. On the margins, it's quite thick, the tympanic membrane. But look, there is an upper part of the bone. When you look at this entire circle where the tympanic membrane is attached, that bone in the upper part is not having a sulcus. Instead, there is a notch over there. Instead, there is a notch which is present here, something like this. So we have a groove which is present all around here, in which it is attached. But in the upper part, the bone is having a sulcus over there. There is a sulcus present over there. So let me just write down this point first. Then only this rest of the thing will make sense. That tympanic sulcus is not present in the upper part. Tympanic sulcus is not present in the upper part. In the upper part, उसकी जगह पर क्या होता है? We have a tympanic notch. Tympanic notch is present. आप मेरी बात समझ में बेटा? There is no groove which is present around in the upper part. चारों तरफ groove है. We have groove everywhere in which the tympanic membrane is attached. But in the upper part, the bone is showing a notch. एक छोटी सी ऐसे there's a space over there which is called as a tympanic notch, but which still has to be covered with the tympanic membrane. Now, we already saw that handle of malleus is attached to the tympanic membrane. Now let's say you're seeing it in this way, that this is the area where the handle of malleus is attached. All the way to the center, there is a handle of malleus which is attached. Please understand this in the sequence zone. There is a handle of malleus. Okay, and we said this point where the handle of malleus is attached in the center here, this is the point of maximum convexity, and that is called as what? That is called as the umbo. That is umbo. The point of maximum convexity. Let me write that. This umbo is the point of maximum convexity. Fine. Now what happens is, we do not have the tympanic sulcus present in this part. So what you see, the tympanic, there are two folds, malleolar folds will be seen running from there to the lateral process of the malleus. आपको याद है मैंने आपको process दिखाया था, lateral process of malleus. So from the margin of this tympanic notch, this is notch beta, this is notch. From the margin of the tympanic notch, the two folds are running toward the lateral process of malleus. Let me write that. This process here is what? That is a lateral process of malleus. Malleus का बोलिए ना. Lateral process of malleus. Right? This one of the fold is called as anterior malleolar fold. If this is anterior side, it's smaller. If this is anterior side, so we have an anterior malleolar fold. And this fold here, I'll try to show it in the picture also to support this thing. This bit here is the posterior malleolar fold. Now the point is, between the anterior and posterior malleolar fold, tympanic membrane यहाँ पर भी और यहाँ पे भी, this is all tympanic membrane only. But guys, this portion of tympanic membrane, the one which I'm highlighting for you right now, this portion of tympanic membrane is loose. So we call it pars flaccida. It's loose. So pars flaccid like loose. And the remaining part of tympanic membrane is quite tense and tight because of sulcus attached. So that is called as a pars tensa. The one which I'm highlighting here, this is called as a pars tensa part of tympanic membrane. So we got two parts of the tympanic membrane. One is called as pars flaccida. So what is pars flaccida? That's flaccid part. That's a loose part which is extending between the two malleolar fold, which is covering the tympanic notch. The remaining tympanic membrane, the major part, the remaining tympanic membrane is called as pars tensa. It's quite tensed. खिंचा हुआ एकदम. That is pars tensa. So that's a two part here, pars flaccida and pars tensa. Now I told you the tympanic membrane, beta, it is slightly slant. It is having an angle of 55 degrees. Moreover, it is convex like this. If I say convex inside, so it is convex like this and it is tilted also. So when you put a light, when you put a light in the ear, so that light will hit the umbo portion and then will be reflected anterior-inferiorly. That light will be reflected anterior-inferiorly. As we already said, it is anterior malleolar fold, so obviously that's the anterior side, and that's inferior. So from the umbo, anterior-inferiorly, you will see a reflection like this in this portion. So you'll see this part is quite bright here, and that is called as a cone of light. There is a cone of light. बहुत simple फंडा है. When you put a torch, when you put a light inside in the ear, in the external ear, and that light hits the tympanic membrane, because of the convexity of the tympanic membrane inside, and also because of the angulation, the light hits the point, and then is reflected anterior-inferiorly because of its orientation, and that is called as a cone of light. So important याद है आपने, कि cone of light is seen where? In which quadrant? In anterior-inferior quadrant. Cone of light is seen in anterior-inferior quadrant. In the anterior-inferior quadrant. Let me show you one real-time picture of the tympanic membrane. थोड़ा सा उससे idea हो जाएगा कि if somebody is literally putting a light on the tympanic membrane, how exactly this will look like. That's a cone of light which is seen in which quadrant? Anterior-inferior quadrant. Look at that. I've saved some pictures for you. Let me just try to show it. That's a picture from the outside. सब चीजें इतनी clear नहीं होती जितना हम उसको draw करते हैं. But yeah, this is how it is, guys. When you put a torch in the external auditory canal, obviously this point here will be the umbo. Let me just keep writing it. This point here, this is the umbo here. This is the handle of malleus. I'm writing H here. There is handle of the malleus which is extending. Okay, so that's a point of maximum convexity. And I hope, can you see the cone of light, beta? Look at this. In the anterior-inferior quadrant here, that is the cone of light. The light reflection, that is a cone of light. if this is the handle of malleus, this is the point where we have anterior malleolar fold. This is the point where you have posterior malleolar fold. इतना इसी तरीके से दिखता है यहाँ पे. And this part of the tympanic membrane जो notch में, this is pars flaccida. Remaining tympanic membrane here is a pars tensa. That's pars flaccida part here, and there's a pars tensa portion of the tympanic membrane. So tympanic membrane is kind of translucent. So even when you put a torch or the light on the tympanic membrane, you are still able to see this umbo portion. You are able to see the handle of the malleus. You can even appreciate the choroid tympanic nerve which will be passing like this. So that there are a couple of structures which can be seen even from the outside because of this translucent tympanic membrane. Although thin layers, but still it is translucent only. Achha, if I show you the tympanic membrane from inside, that's a view of the tympanic membrane from outside. When you saw it from inside, when you see the tympanic membrane from inside, the important thing that you will see that the choroid tympanic nerve will be seen running like this, very close to the very close to what pars flaccida here, right? इसको draw करने की जरूरत नहीं because you don't have to draw multiple diagrams just for the one short note question here. But look at this picture, which will give you a fair idea about it. Look at this. Don't try to overlook things, but the tympanic membrane is removed from it. Now, first of all, look at this. The tympanic membrane is cut. First of all, look at this portion here, which is having a rim here in the groove here, and this sulcus, sulcus आपको दिखा, that is a tympanic sulcus. And this would be the region. अगर मैं यहाँ पे draw करूँ आपके लिए, there is anterior malleolar fold. You can see it already. They have drawn it. There is anterior malleolar fold. There is posterior malleolar fold. So this region here is the pars flaccida part, and because they removed the tympanic membrane, so this would have been the pars tensa. The rest would have been the pars tensa here in this region. Don't try to look everything inside. That is a different thing here. Now, can you see the nerve which is passing from the posterior canaliculus and then going into the anterior canaliculus, very close to the handle of the malleus, and in close relation to the pars flaccida? That is choroid tympanic nerve. So that is a choroid tympanic nerve. It's better if I, as I said, you don't have to draw it in your exam, but just for your understanding, I'm making you draw this. When you look at the tympanic membrane from inside, that's how it's going to look like. This is the malleus bone, right? And let's say if this was the pars, that is malleus. That's a view from inside. This is pars flaccida. These are the two folds, anterior posterior malleolar fold. So you will see facial nerve. Facial nerve will be running on the posterior wall, and there is a branch of facial nerve. The choroid tympanic nerve will be seen running in close relation to the pars flaccida, and then going and entering into this anterior canaliculus. It enters through the posterior canaliculus and goes out of the anterior canaliculus. I told you choroid tympanic is not doing anything in the middle ear cavity. It is just very close to the tympanic membrane. So फायदा नहीं नुकसान ही है, because tympanic membrane, while incising the tympanic membrane, this nerve can get injured. So that's the facial nerve branch, and this nerve is the choroid tympanic. Right. So this is about the part of the tympanic membrane and how we divide it here. Now, very quickly coming to the blood supply, venous drainage, and all that. Blood supply to tympanic membrane or to the arterial supply, if I start with, आपको दोनों का पता है. Outer surface, see, I hope you remember the branches of maxillary artery guys that go from there itself, and the inner surface. So let's see if you can think about it. Outer surface and inner surface. When you look at the outer surface of the tympanic membrane, I told you there is a branch of maxillary artery. Remember, first part of maxillary artery was giving 5 branches. आम आदमी, A, D, M, I. One of the artery was called as the deep auricular artery. Deep auricular artery supplies the deeper surface of the auricle and outer surface of tympanic membrane. Whereas anterior tympanic artery तो middle ear के अंदर जा रहा है, so that supplies the inner surface of tympanic membrane. So outer surface of tympanic membrane is supplied by the deep auricular artery, which you all know is a branch of first part of maxillary artery. We've discussed the maxillary artery, आपको याद हो, you can always go back and see the first part of maxillary artery. Whereas the inner surface is supplied by the anterior tympanic artery, which also is a branch of first part of maxillary artery. So first part of maxillary artery is taking care of both the surface of tympanic membrane, outer and inner. Whereas the inner surface of tympanic membrane is supplied by one more artery, which is a branch of posterior auricular. So there is an artery called as posterior auricular artery. Posterior auricular artery gives an artery inside there called as stylomastoid artery. And there is a branch of stylomastoid artery called as posterior tympanic. ज़्यादा याद ना है तो simply write posterior tympanic. But just to tell you that inner surface is also supplied by the artery called as a posterior tympanic branch. Posterior tympanic branch of stylomastoid artery. Stylomastoid artery, and stylomastoid artery is a branch of posterior auricular artery. Posterior auricular artery. And just to remind you guys, we already know that maxillary artery ho ya posterior auricular artery ho, they both are the branches of what? External carotid. They are both direct branches of external carotid artery. Just to give you the entire continuation here, the outer surface is supplied by the deep auricular artery, branch of maxillary, which is a branch of external carotid. Inner surface is again by the maxillary and also by a branch of the posterior auricular, which in turn is a branch of external carotid. Venous drainage. Venous drainage is, again, if I talk about the outer surface, see, if I talk about the outer surface, the venous drainage of the outer surface goes into the external jugular vein. Now think about, see, artery which is supplying the outer surface is a branch of external carotid artery. And if you think of external carotid artery and the vein, a superficial vein which is running in this region here, and that is what external jugular vein. Moreover, superficial temporal artery is also supplying the ear, external ear here. So outer surface of tympanic membrane से कोई भी vein आएंगी, even if they drain into superficial temporal vein or posterior auricular vein, ultimately they both are together forming the external jugular vein. So ultimately, outer surface is draining into external jugular. Whereas the inner surface of tympanic membrane is draining into the sinus, and that is a transverse sinus. Dural venous sinus, guys, transverse sinus. It drains into the dural venous sinus. It also drains into the venous plexus around the eustachian tube or auditory tube, but not important. Ab transverse sinus yaad rakho, that is like more than enough. Outer surface into external jugular vein, inner surface into the transverse sinus. Lymphatic drainage, as I said, we just got to complete this thing. Lymphatic drainage, the lymphatic drainage of the ear, again, the outer surface and inner surface. So everything here about the tympanic membrane, you have to go along with inner and the outer surface. Whether it is outer surface or inner surface, tympanic membrane, inner तो नहीं सकता because there is no lymphatic drainage toward the inside here. Brain का तो lymphatic drainage होता नहीं है, so there is no lymphatic drainage toward the inside. So all the lymphatic drainage is toward the outside only ultimately. So whether it is outer surface or inner surface, like whether it is outer surface or inner surface, overall the lymphatics from the tympanic membrane are going into the pre-auricular guys, इसको parotid lymph nodes बोलते हैं. In front of the auricle, we also call them parotid lymph node. Pre-auricular and into retropharyngeal, that is behind the pharynx. Pre-auricular and retropharyngeal lymph nodes. Lymphatic drainage, whether it is outer or inner surface, it all has to come outside only. So it is not going toward the cranial cavity. There is no lymphatic drainage inside the cranial cavity. So lymphatic drainage के लिए इसको बाहर ही आना पड़ेगा. So it is draining into this parotid lymph node, which are called as pre-auricular, and the retropharyngeal, the one which is behind the pharynx, the retropharyngeal lymph nodes. The important thing to remember here in the short note here is the nerve supply. We talked about the nerve supply of the external ear. Now what is the nerve supply of the tympanic membrane? Now guys, nerve supply of the tympanic membrane, again we got to see it in two parts, the outer and the inner. If this is the outer surface, let us say this is the outer surface here. The anterior inferior part, let me go with the same diagram which the anterior inferior part, nerve supply is different, and this is posterior superior. Obviously if one is anterior inferior, the other will be posterior superior. But the posterior superior is supplied by the auricular branch of vagus. Arnold nerve, that is also giving up the branch inside. Auricular branch of vagus, which is basically the Arnold's nerve. Anterior inferior quadrant or anterior inferior part is supplied by the auriculotemporal nerve. Supplied by the auriculotemporal nerve. So when you look at the outer surface of tympanic membrane, anterior inferior part, as per anterior inferior quadrant, you have a cone of light. Anterior inferior part where the cone of light is there, that portion is by the auriculotemporal nerve. Posterior superior is supplied by the vagus nerve, the auricular branch of vagus nerve, or you can call it Arnold's nerve. What about the inner surface? The inner surface is supplied, inner surface is supplied by the tympanic branch of glossopharyngeal nerve. You remember guys, when we talked about the ninth nerve, we said ninth nerve goes into the medullary cavity and forms a plexus on the promontory, which is called the tympanic plexus. So that is the one which gives our branch. Tympanic branch of glossopharyngeal nerve through tympanic plexus. Through tympanic plexus. So that's the overall nerve supply of the this tympanic membrane. Outer side. So total, if I'll say overall there are three nerves: auriculotemporal nerve, vagus nerve that is on the outside, and the inner side it is the glossopharyngeal nerve. That is the tympanic branch of glossopharyngeal nerve via the plexus. Clinical anatomy में एक चीज याद रखना इसमें important. In the clinical anatomy, cone of light is again one thing that is you should tell them on the clinical anatomy that while examining the external auditory canal and tympanic membrane, the cone of light is seen in the anterior inferior quadrant. The other important clinical anatomy here is like if there is a medullary infection and if you want to drain the pus or if you don't want to drain the infection of medullary cavities, then you have to put an incision on the tympanic membrane. But putting an incision on the tympanic membrane is called as a myringotomy. Incision to tympanic membrane ko we call it myringotomy. Myringotomy or myringotomy. This myringotomy, आप जब incision लगाते हो उसमें तो obviously you want to drain the pus from middle ear. Middle ear infection में otitis media बोलते हैं. Middle ear infection हो जाता है तो you can drain them outside by putting an incision on the tympanic membrane. बाद में heal भी हो जाता है, no big deal. But you have to be careful about what? In the myringotomy, you got to be careful about what? About chorda tympani now. About chorda tympani because it was very close to the tympanic membrane, close to the pars flaccida part of the tympanic membrane, very close to the membrane. So you got to be very careful about the chorda tympani now. And that's why we don't prefer to give an incision in the upper part of the tympanic membrane because chorda tympani वहीं पे situated है. So we prefer to give it in the lower part of the tympanic membrane. So this is about the tympanic membrane. I guess that's a good enough content to write about the membrane. Make sure you tell about the three layers, tell about the pars flaccida and pars flaccida and the pars tensa, and rest of the things you've got to explain it in the outer and inner. Arterial supply, venous drainage, and especially the nerve supply, the outer and inner aspect. So very quickly, let's talk about the ear ossicles. Ear ossicles. Again, a short note question. Not a popular. Any of the question from the middle ear or any of the question from the ear or eye. मैं orbit की बात नहीं कर रहा, eye की बात कर रहा हूँ. From the eye or ear is not a very important question. If I have to make a list of important questions, I will not give them a single question from the ear, except the tympanic membrane maybe as another short note, nothing else. So even ear ossicles you should know about. The chances of getting a question from that, rare, quite rare. There were three ear ossicles, malleus, incus, stapes, and if you understand a little bit about the first and the last one, especially about the malleus and the stapes, then you will also understand that how the muscles are acting on it. There is a muscle which is acting on the malleus bone, which is called as the tensor tympani muscle because it tenses the tympanic membrane, and there is a muscle which is acting on the stapes, that is the stapedius muscle. I want this you will please draw it with me, and then we'll see what are the different parts. So एक ही diagram में सब कुछ करेंगे. We'll just go nice and easy in this. This here is the head of the malleus. We have this lateral process. And there is an anterior process also. That's a malleus bone. Just draw it with me. That's a malleus bone. We will be writing everything in the diagram. कुछ बाहर लिखने की जरूरत नहीं, so that would be good enough for this discussion. Malleus, hammer-like bones. Then incus, like an anvil. This here is the body. We have a short process, and then we have a long process like this. And the third, that is stapes. Right, so these are three ear ossicles, the malleus, incus and stapes. Malleus is the largest and stapes is the smallest. If I look at the feature of these bones, guys, agar malleus se shuru karte, so this here is the head of the malleus. There is a head of the malleus, and the important thing to remember from the head is that head of the malleus is not exactly at the level of the tympanic membrane, it is above the level of tympanic membrane. There was something which I want to show you here. You've got to keep looking at this picture simultaneously, then only this thing will make sense. If you look at this picture once again, can you see the head? This is the head of the malleus here, and if I just draw a line from the level of tympanic membrane, then this is the one. But medullary cavity is not only this, we have an extension, upper extension of medullary cavity, which is called as epitympanic recess. Epitympanic, above the tympanic cavity. Medullary cavity is also called as tympanic cavity. And this portion of the tympanic cavity, the one which I am highlighting right now, is present above the level of the tympanic membrane. This is tympanic cavity, this is epitympanic recess, extension of the tympanic cavity above. The head of the malleus is extending into that. The head of the malleus is extending into that. And also you can see the major part of the body of the incus also. So if I take you back to this picture, about the head we said about of the malleus is in what recess? In the epitympanic recess. Epitympanic recess. There are two ligaments which are attached to the head, and you will understand those ligaments which once I'll show you the picture. Just write this with me and you will understand the two ligaments immediately when I show you the picture. We have a ligament attached to it, ligament which are just attached होते हैं. Those two ligaments have a lateral and superior ligament. So it gives attachment to, I hope you have enough space to write a lot of things, attachment of superior and lateral ligament. So head will give attachment to two ligaments, that is superior ligament of the malleus and lateral ligament of the malleus, and that will make sense once you see the picture. After the head, the next part here, this portion is called as the neck. That is the neck of the malleus. कुछ ज़्यादा इसमें है. Neck was the part which was present against the pars flaccida. This was the portion which was present against the pars tensa, and this portion is present close to the pars or against the pars flaccida part. The important thing is this. That is what? That is the lateral process. आपको अगर याद हो, we said that lateral process is giving attachment to what? To the malleolar folds. एक बार वापस लेके आता हूँ आपको. Look at this picture of the tympanic membrane. See, that's what we said, guys. This here is the lateral process. I'm just with this lateral process, and we have the anterior malleolar fold and posterior malleolar fold here. So when you look at the lateral process, the malleolar folds are attached to it. So that's the lateral process, attachment of malleolar folds. What process is this one here? This process is facing anteriorly. This process facing anteriorly. That's a side view basically. So that process is facing anteriorly, okay? And this is called as anterior process. So एक lateral process होता है इसमें, and there is another process that is called as anterior process. Anterior process gives attachment to the ligament which is called as the anterior ligament of malleus. Anterior ligament of malleus. ये सब समझ में आएगा when I show you the picture. Anterior ligament of the malleus. And guys, this part is called as the handle. This part is called as the handle. So we have a head, neck, lateral process, anterior process, and the handle. बताने की जरूरत नहीं. Handle was attached to what? Handle was attached to the tympanic membrane. It was attached to the tympanic membrane. Head was attached to the tympanic membrane. And remember one thing, because the handle is attached to the tympanic membrane, and this handle was pulling the tympanic membrane inside, and to keep the tympanic membrane tensed, we need a muscle to attach to the handle और उसको और अंदर pull करे, and that muscle is tensor tympani. Tensor tympani. Remember that, guys, the two tensor muscle, tensor veli palatini and tensor tympani. So tensor tympani will be attached to the handle of the malleus. It is supplied by the mandibular nerve. We said the two tensor muscles are supplied to mandibular nerve. So this tensor tympani muscle is attached to the handle of the malleus. Handle of malleus is attached to what? It is attached to the tympanic membrane, and it pulls the tympanic membrane inside, tensing the tympanic membrane. That's why the name of the muscle is tensor tympani. Tensor tympani. Medullary का orientation समझने के लिए you have to understand these bones, especially the ligaments and the attachment of the first and the last one. So I hope this makes it clear that the parts, at least head, neck, lateral process, anterior process, and the handle here. Let me just again take you back to one of the picture of the medullary cavity. Okay, so this is again a wonderful picture to tell you something. This guys, we said this is the handle here, and the handle, can you see a muscle attached there? This muscle is coming from the anterior wall of medullary. What we have discussed here, what we will discuss in the next class. It is coming from the anterior wall of medullary, and that muscle, the tendon over there, is a tendon of tensor tympani. That's a tensor tympani tendon. Every time this tendon will pull it inside, the more it pulls inside, the tympanic membrane will get sucked inside toward the medullary cavity, and that is tensing it here. That is producing the tension over there. Similarly, you can see from the posterior wall of medullary, there is a pyramidal prominence present over there, and a tendon is coming out of there. That is called the tendon of stapedius, which is attached to the stapes bone. It is attached to the neck of the stapes. That is the stapedius muscle. So tensor tympani कहाँ पे attached है? It is attached to the handle of the malleus. देखो एक और चीज समझने की कोशिश करो. Let's try to understand it from this picture itself. Although I'll try to post a different picture to make you understand that. Guys, we said that head is giving attachment to the lateral ligament and superior ligament, but a lateral ligament will be attached like this, and superior ligament will be attached like this. To make sense, this head of the malleus bone is having attachment to anterior ligament and superior ligament, whereas posterior ligament is attached to which bone? This one. That is to what bone? That is to the incus. So we have a posterior ligament which is attached to the short process of the incus bone. So coming to the incus bone, coming to the picture which is showing the same thing here. So what you see all in the incus bone is this is incus. This portion of the incus is called as the body. This process here is the short process. अब उसमें से एक ही चीज याद रखने वाली है कि this short process is giving attachment to the ligament which is called as a posterior ligament. So anterior ligament and superior ligament is attached to the malleus bone because that is more toward the lateral side. So anterior and superior to the head. But posterior ligament, जिसको पीछे attach करेगा to the posterior wall, that is to the short process of the incus. This process, this is a long process of the incus. This here is a long process of the incus, and if you go along with the long process of incus in the lower part, this small dilatation, which is basically providing a sulcus kind of thing, a depression inside for the attachment of this head of the stapes. This is what we call as the lentiform nodule. This is the lentiform nodule. So the one which I'm highlighting, these are the parts of the incus bone here. There's a body, there's a huge body over there which is having attachment to the head of the malleus, the short process, the long process, and the long process is ending as a nodule, which is having a depression inside that is called as a lentiform nodule. And then finally coming to the smallest, the smallest, the ear ossicle, that is the stapes. The parts of the stapes includes, this here is the head, as you can see, that's a small head over there. This here is the neck, the head, the neck, and then we have the crus. We have an anterior crus and posterior crus. But two crus here. This, let us say, is the posterior crus. This is the anterior crus. Anterior crus थोड़ा सा बड़ा होता है, posterior से, anterior crus and posterior crus, and this is called as a foot plate. Foot plate of stapes. It's called as a foot plate of stapes. दो चीजें याद रखनी है यहाँ पे खाली यहाँ पे. One, that the neck of the stapes is the one which is giving attachment to what muscle? To the stapedius. Neck is giving attachment to the stapedius muscle. And second, the foot plate of the stapes is attached to what window? It is attached to the oval window. It is attached to the oval window of the medial wall of middle ear. This is something that you should know about the ear ossicles. As a matter of fact, middle ear, the content of the middle ear, the main content of middle ear is air. First main content is air. Then mucous membrane. The three ear ossicles here. Apart from three ear ossicles, we have the two joints. Now, what is the joint here, guys? The joint that you see, which is present between the malleus and incus, this joint between malleus and incus, and there is a joint between the incus and stapes. So that is called as the incudomalleolar joint. Let me write that also here. This joint here, this is called as the incudomalleolar joint, and this incudomalleolar joint is an example of saddle joint. It's a type of synovial only, it's a saddle joint. And this, the joint between the foot plate of the head of the stapes and the lentiform nodule of the incus, that is called as an incudostapedium. Incudostapedial, let me just write it here. The joint is the incudostapedial joint, and that's a good question. Incudostapedial joint is an example of ball and socket. We just have 4 ball and socket joints in the human body: shoulder, hip, then one in the foot called as TCN, talocalcaneonavicular joint, talocalcaneonavicular, or एक middle ear के अंदर this one, that is incudostapedial joint. So if you know this much about the ear ossicles, that is like probably more than enough. And honestly, ये भी कोई नहीं पूछने वाला. So nobody is going to ask you this much detail here, but you should know these details to understand the middle ear better. That when I say anterior ligament of malleus, if I say lateral ligament, if I say posterior ligament, so what ligament is attached where? The tensor tympani muscle is handling the handle of the malleus. Handle of the malleus is attached to the tympanic membrane. It will pull it inside. If I say the stapes, the foot plate of the stapes is attached to the window on the medial wall of middle ear called as oval window. The muscle attached to the neck of the stapes is the stapedius muscle. दो muscle होते हैं middle ear के अंदर, एक stapes पे attached है और एक handle of malleus पे attached है. So this is something that you should know about the ear ossicles. I don't know if I have a picture for the ear ossicles separately. That is, the diagram is good enough, but just to, apart from this, but there is a foot plate here. I hope you can see this diagram here. There is a foot plate of stapes. Let me just try to enlarge this picture a little further. So all that we discussed here, that's the head here. This is the neck. That is a lateral process. This is handle. This is anterior process. आप सामने से देख रहे हैं, so it's an anterior process. This here is the short process of the incus. That is a long process of incus. That is lentiform nodule. This is the head of the stapes. And then you have a very small part that is the neck. We have anterior crus. We have posterior crus. Anterior crus थोड़ा बड़ा होता है. And this is the foot plate of the stapes, which is attached to the medial wall of middle ear, and that window, you can see the shape, that is called as the oval window. Round window नीचे होती है, that's a different thing. We will discuss that separately. There's a oval window which it is attached to it. Right? Out of these 3 ear ossicles, we said the largest is the malleus, smallest is the stapes. Stapedius is also the smallest muscle in the human body. And head of the malleus and the major body of the incus, they are not present in the tympanic cavity, they are present in the epitympanic recess. They are present in the upper part of the tympanic cavity, that is epitympanic recess. So your middle ear cavity, honestly speaking, the middle ear cavity is absolutely very, very difficult to understand if you go with an anatomical diagrams in it. If you look at the pictures given in PD Chaurasia or any of the Atlas, Natus Atlas or Cunningham, they usually give these pictures and they keep showing the different walls of the middle ear from different angle, and it becomes really difficult to understand exactly how the middle ear is oriented. So our first job is to understand the middle ear, and then we can compare it with the real-time pictures. So there is one accepted diagram for that. There is a diagram that I'll draw which will look like a box of television or any cubicle box basically. Because middle ear is having all the walls, it is having anterior wall, posterior wall, lateral, medial, roof and the floor. All the walls are not proportionate, but let's presume if all the walls are proportionate, and that's how we try to imagine the middle ear. It is relatively easy to understand. आप ऐसे imagine करो, you people are sitting inside, you must be sitting in the room right now. Now that room is having 4 walls, a roof and the floor. So we basically have to think about that we all are sitting inside the middle ear. And let's say if I'm sitting in this room here, I'm facing forward here. So this side, this wall will be the lateral wall for me. This wall, if I talk about this, let's say right middle ear. If I talk about my right middle ear, so this will be the lateral wall. This will be the medial wall. The one in front will be the anterior wall. The one behind will be the posterior wall. This roof and the floor. So that's how I also wanted to understand this. So to understand the middle ear, let us draw a diagram and keep talking about one wall at a time, right? The kind of diagram which are given in the books, you don't have to draw them because the diagram which I'm going to make with you, it is universally accepted. So you can draw the diagram in your exam also. ऐसा नहीं सोचना कि middle ear doesn't look like this, so I can't draw it. No, nothing like that. I'll come back and we'll explain this image, I'll explain this image, we'll explain this image as well as this image here. But to understand all these images, we first have to understand what are the different features of the middle ear and how they want to look like. So I want all of you to please draw it with me Take your time, go nice and slow, but this is a diagram which, as I said, you can replicate in your exams also. So as I said too, if I presume that middle ear is like a box, a cubical box, or like a room, so this will do something like, we all do these kind of pictures to draw the box. This is a three-dimensional picture of the box. Aram se, take your time, and then, because we got to understand everything on this one image itself. The entire discussion on the middle ear is this image. Okay. As I said, we are considering it like you are looking at a wall. Now, let me just give you an orientation, guys. If I turn like this to one side, okay, so that's how you're looking at this ear. So the first thing that you will come across, पहली चीज करेगी आपको tympanic membrane. When you go inside the ear, सबसे tympanic membrane. So tympanic membrane is the lateral wall. So if I remove the lateral wall, if I remove the tympanic membrane, then only you are inside the middle ear cavity. तो आपको ऐसे सोचना है कि you are looking at someone's ear from the side, and when you remove this tympanic membrane, a big tympanic membrane, let's say, was present here, which was present here, forming the lateral wall, and that is removed. So again, just for the demarcation, this wall which I'm highlighting right now here is a medial wall. Lateral wall was tympanic membrane, which is removed. That's why we are able to see inside. And I'm just highlighting it so that you can differentiate this wall from the other walls. So guys, that wall over there is a medial wall. Now, but a medial wall is the one which is medial to the medial wall will be the internal ear. If this entire box here is a middle ear for me, this everything here is a middle ear for me, whatever we'll be having here, the three ear ossicles, the nerve, the muscles will be there inside. Agar main yellow wala membrane, if I remove that part, so you will enter into which ear? Internal ear. So again, the view is like this. You started from this side, you remove the tympanic membrane, so you are looking into the middle ear cavity. Middle ear cavity में तो सबसे अंदर आपको wall दिख रही है, that is a medial wall. You're looking at the medial wall of middle ear, and if you remove that medial wall, the one which I've highlighted here, you will enter into which ear? Into the internal ear. You will enter into the internal ear. So I hope you got this. That the yellow highlighted part is a medial wall. Okay. Before we go to the features, let me tell you that what are the different names given to the walls here. Like first of all, let me start with the roof here. The roof of the middle ear is basically separating the middle ear from the middle cranial fossa. When you see the cranial cavity, there is a plate over there. We talked about it. That is called the tegmen tympani. Tegmen tympani. So this plate over here, this one, is called the tegmen tympani. Tegmen tympani, and this is what is forming what? It is forming the roof. This is the roof of the middle ear cavity. This is the roof of the middle ear cavity. Tegmen tympani. So tegmen tympani is basically a part of the temporal bone only. It's a very thin plate which is separating the middle cranial fossa and the middle ear. अगर ये plate ना हो, तो that means your middle ear will be in direct contact with the meninges. What is above it? Above this will be the meninges. There will be dura mater, there will be arachnoid mater, and there will be brain. So let's say if I draw something above this, so above that, what will be there? There will be the dura mater. Above that will be the arachnoid mater, and above that there will be brain. Let's say these are the gyri and sulci. Just drawing it roughly here, so that is basically part of the brain here. So tegmen tympani is a thin plate of the bone which is separating this middle ear, everything below is middle ear, to above what? To this part. It is separating it from the meninges. This is, let's say, D is for the dura mater. This blue here, it is for the arachnoid mater. And as you know, that pia mater is adherent to the brain, so this is brain here. Basically, the temporal lobe is present in this region. Right? So that's all about the roof. Roof means zyada kuch nahi hai. That roof of the middle ear is formed by the tegmen tympani. Ye kuch points hai which I also request you to please keep writing them separately. I'll come back to this diagram. So, we started with the roof here. Tegmen tympani. So just remember the word, that's enough. Tegmen tympani, which is a part of what bone? It's a part of temporal bone. It's a part of temporal bone which separates middle ear cavity from the middle cranial fossa, or you can say from the brain. Temporal lobe of the brain. Right? So guys, this is the roof here. Okay. अब बात करते हैं floor की देखो. Floor, the one that you're looking at here, this obviously the one which is below here is the floor. Floor of the middle ear, it is called the jugular wall. Why we call it a jugular wall? Because the superior bulb of internal jugular vein is present just below that. Superior bulb of internal jugular vein. It's always good to draw these things, guys. Let us say this here is the internal jugular vein. In fact, I should draw it like this, that it's a superior bulb. So this here is the superior bulb of internal jugular vein. When the internal jugular vein is formed, it formed like a bulb actually. Which bulb head is present exactly below the floor of the middle ear. So that's the superior bulb of the internal jugular vein, and that is the reason. The floor is also called as the jugular wall. Floor is also called as jugular wall because it is in relation to the internal jugular vein, or you can say the bulb of, or more precisely, the superior bulb of internal jugular vein. One nerve will also come out from the floor. I'll tell you what is that, but let's wait for it. Okay. So I hope you understood that. This is a simple part. Roof and the floor. Roof is by tegmen tympani, and floor is by the jugular wall. When I will show you the real-time picture, you will be able to understand everything in here. I want you to पहले एक बार थोड़ा सा memorize कर लो कि what structures are present in which wall. Then we will look into the atlas images, and your understanding will definitely improve about how these structures are placed. Okay. But coming to the anterior wall, because that's an important part. Anterior wall, the one which is in front of the middle ear, is also called as a carotid wall. Now this is something we have already discussed when we talk about the facial nerve also. First of all, it is in relation to the internal carotid artery. The anterior wall of middle ear is in relation to the internal carotid artery, and make sure it is only the lower part, not the upper part. So this here is the internal carotid artery. Internal carotid artery. This is the anterior wall I'm talking about, right? And that's the lower part. And upper part of the anterior wall is having two very, very important openings. Now the opening that you see in the upper part here, the opening that you see in the upper part is basically transmitting a muscle inside the middle ear, and that muscle is the tensor tympani. Tensor tympani. So anterior wall se muscle enter karta, the muscle which enters from the anterior wall, that muscle is tensor tympani. If I may just draw this muscle here, let us say the muscle comes in here. That's a muscle coming in here, and that's how it is entering into the middle ear. Thoda sa so curve kar lena, it will be more helpful to understand in the later part. So this is the muscle that is tensor tympani, and obviously this opening is the opening for the, or you can say it is a canal for tensor tympani. Tensor tympani or tensor tympani, whatever we call it. Remember, tensor muscles are supplied by the mandibular nerve, so that's the same tensor tympani we're talking about, and it is present on the anterior wall. Although how it is reaching the lateral wall, we will discuss that, but that is there in the anterior wall. Below that, there is another important opening present on the anterior wall, and that is the opening for the eustachian tube. Auditory tube or eustachian tube, right? That's what we have been talking about. That is eustachian tube or auditory tube. So this here is called the tubal opening. This is called as the tubal opening. Tubal opening. Obviously, this tubal opening is for the eustachian tube. We know that eustachian tube, where it is opening in the nasopharynx, right? Behind the inferior nasal concha. So that eustachian tube opening, that is a medial opening, and it is a lateral opening, which is the anterior wall of middle ear. So when you think of the anterior wall of middle ear, there are four important things. One still is left. I'll tell you what is that. One is that if you start from above, there is a canal for tensor tympani muscle through which that muscle will enter into the middle ear, anterior wall. That's how I'm pointing my finger also. Then there is an opening of the eustachian tube. Obviously, when there's a tube which is connecting the nasopharynx and ear, so that tube is going backward, will go to the anterior wall of the middle ear. So it is opening on the anterior wall of middle ear, and the remaining lower part of the anterior wall is basically having internal carotid artery, and we have a sympathetic plexus around the internal carotid artery, which nerve will also go inside. We will talk about that. We will come to that in a while. Okay. Now there's another important thing, guys. This canal that you're looking at, which is the canal for tensor tympani, a small bony slab will also be seen extending in the form of this canal only. There's a bony slab which is seen. Let me draw it in this way. And this bony slab here, let me put a hash sign here. If you have space, you can do that. Otherwise, you can write that name also. Guys, the hash which I drew, that bony extension is called as the processus. That is called as a processus cochleariformis. Processus cochleariformis. But a processus cochleariformis is a bony projection which is basically the same canal which is transmitting the tensor tympani muscle toward the middle ear. And what is the function of this bony projection? This is a bony projection. And the function of this bony projection is that it acts as a pulley. It acts as a pulley for tensor tympani. देखो यार, tensor tympani muscle बेटा, it needs to work on what tympanic membrane. That's a word. That's why the name is tensor tympani. Now look at me please. All of you just pay attention to me. Let me turn my head to one side. Now this is my anterior wall of middle. Let us say this is my anterior wall of middle ear. Now muscle entered from the anterior wall, the tensor tympani muscle, but it has to stretch what? Tympanic membrane. Now let me turn my face again. So imagine the tensor tympani muscle was coming from the anterior wall, but it has to stretch what? Tympanic membrane. And tympanic membrane is found on which wall? Lateral wall. And last discussion, we said that there is a handle of the malleus which is attached to the tympanic membrane. So let us say this, my stylus here is the handle of the malleus. So this tensor tympani muscle running in this direction is not useful. We have to turn this muscle in this direction and attach it to the handle of malleus. And how can one muscle or tendon be reflected or can turn toward in another direction? That is by a pulley. And that pulley is formed by a bony projection called as a processus cochleariformis. So this is a bony projection which is basically present between these two openings, between the tubal opening and the canal for tensor tympani, or ये tensor tympani muscle को allow करेगा to turn toward the lateral side and then attach to the handle of malleus so that it can pull it inside, and that's why tympanic membrane is something like this. Remember that umbo, that point of convexity, is because of the pull of this muscle itself. So this is all about the anterior wall. We have a canal for tensor tympani, we have a processus cochleariformis from where the tensor tympani muscle will curl toward the lateral side. We have a tubal opening which is giving obviously, which is the medial opening, or I should say it is not the medial, sorry, what is the posterior opening or the opening of the eustachian tube toward the middle ear, and the internal carotid artery is in relation to the lower part of this. And that's the reason the anterior wall is also called the carotid wall, because of internal carotid artery. So this is the anterior wall that you saw, and we also call it the carotid wall. It is also called as the carotid wall. Makes sense? Tegmental tympani, jugular wall, carotid wall. So till now we have just discussed the three walls here. Now before I discuss the remaining, we have discussed three walls. We've got the medial wall, the posterior wall. Lateral to already discussed whether it's tympanic membrane. So before I come to the most important medial wall and the posterior wall, I need a very quick feedback, because this diagram is I wanted to just tell me that if you are able to understand this diagram here, if you are oriented at what is lateral, medial, anterior, posterior here, don't worry about how exactly these things will look like in middle ear. That I will do. That I will just show you the pictures and I will label that for you. If you understood this anterior wall, floor, and the roof, then the rest of the part is not difficult to understand in fact. See, before I go to the posterior wall, I tell you about this wall. There's a medial wall here. Okay, wonderful. Look at this medial wall, the one which I've highlighted here. Guys, we know that medial wall, the one which I've highlighted, inside that medial wall is internal ear. And internal ear में क्या present है? Cochlea. See? So cochlea, the first turn of the cochlea, cochlea will make a turn, उसको बोलते हैं basal turn of cochlea. The very first turn of the cochlea or the basal turn of the cochlea will produce an elevation here on this medial wall, and that elevation is called as a promontory. So this here is the elevation present on the medial wall, and this elevation which is present on the medial wall is called as a promontory. That is called as a promontory. I'll just keep writing them in short so that so PM is for the promontory, right? Then the three ear ossicles, malleus, incus, and stapes. We know that stapes is the one which is attached to the medial wall, and stapes is attached where? Posterior superior to the promontory, guys. This is promontory, and posterior superior यहाँ पर कहीं होगा. Posterior superior to the promontory, the foot plate of the stapes is attached, and because the shape of the foot plate of the stapes is like an oval, So this window is also called as a oval window. This is called as an oval window. I should write that in short actually. That is called as an oval window. Location is important. Posterior superior. It is posterior superior to the promontory. That is an oval window where the foot plate of the stapes will be attached here. But let's keep writing all these things here. And posterior inferior to the promontory. Posterior inferior to the promontory is another window which is called as the round window. As I said, I should not be writing all this in here. Let me just write round window. RW. Oval window, round window. Okay, let me just quickly write about these features. So as we said, now we are looking at which wall? We are looking at the medial wall of middle ear. And this is the only wall on which separately a short note, a very short note can be asked on it. Usually the short note is on the middle ear itself. Like if you ask, they might ask you a 2 mark kind of question or 3 mark kind of question on the medial wall. Out of all the wall, medial wall and the lateral wall, that is tympanic membrane, are the most important. Okay, medial wall we saw that one of the elevation is the promontory. Reason for the promontory is it is due to the basal turn of cochlea, the first turn of the cochlea. The basal turn of cochlea or the first turn of cochlea forms the promontory. That's one thing. Another thing on the medial wall we saw that is a round window and oval window. The oval window was the place where the foot plate of stapes is attached. You know the location, that is posterior superior to the promontory. It is posterior superior to the promontory, the oval window. And round window is the place where secondary tympanic membrane is present or attached. Look, what exactly is the secondary tympanic membrane? That is a subject of discussion in the internal ear. Just, I hope you know about it, but let me just give you a very quick feed about it. You know that cochlea is having 3 tubes inside. There's a kind of 3 tubes inside the cochlea, right? So there's a scala vestibuli, there's a scala tympani, and so what happens is when the oval window pushes the fluid inside the cochlea, that fluid will obviously through the cochlea it is pushed, and that wave which is created by this push of this oval window will come back from the apex of the cochlea and comes back toward the middle ear. Imagine the middle ear is completely bony and it is not allowing any displacement of the fluid, so this oval window will never be able to push the fluid inside. So I'll give an example do. If this is a tube here, you know physics more than me, right? If this tube is filled with water, completely with water or fluid, if you push this through a paddle or something, this paddle will be able to go inside and push this entire fluid and can push that if there is a flexible membrane attached at the other end, so that this membrane can get stretched and the fluid is displaced here. When this foot plate of the stapes or this handle comes back to its position, this membrane will get straightened here. So there is a small window which is present inferior to the promontory, which is called as oval window, and it is having a membrane present on it. It's not a bone, it is a membrane present on it, and that membrane is called as a secondary tympanic membrane. Because every time tympanic membrane vibrates, understand this, every time tympanic membrane vibrates, all the 3 bones or the 3 ear ossicles will also vibrate. When stapes will vibrate, it will push the oval window. When the oval window is pushed, the fluid inside the cochlea is pushed, and that displaced fluid will come back and will hit this round window, which is having a secondary tympanic membrane. So every time you see tympanic membrane is vibrating, this will also vibrate like this. Tympanic membrane vibrate from there, and this round window, also oval window and round window, of course, they will also vibrate along with it. So that is a place where the secondary tympanic membrane is present here. So basically, यहाँ से cochlea start हो रहा है, अंदर जा रहा है, और जो वापस आ रहा है, end हो रहा है, that is ending at this